The trials for the TDM1 show from 0.8 to 1.5% cardiotoxicity, and also TDXT patients observed reported some cardiotoxicity. SG is not reported to do cardiotoxicity. The most important thing in managing cardiotoxicity in patients receiving EDC is baseline screening and monitoring during the treatment. The patient should be evaluated if he received previous cardiotoxic drugs, cardiovascular history, physical examination, lab tests like cardiac enzymes, ECG, or thoracic echo. The European School of Cardiology recommended that the patient with treated with ADCs having symptomatic mild to moderate can continue this treatment, but with giving cardioprotective drugs like ACE inhibitors or ARBs or beta blockers. Symptomatic mild to moderate treatment interruption should be done, and asymptomatic severe cardiotoxicity also treatment interruption should be done. This also is a treatment algorithm for patients receiving TDM1 either in the early breast or with a static setting, and on the right, the treatment algorithm for monitoring and managing cardiotoxicity related to TDX. GI toxicity are frequently reported in patients with EDCs, most related to payloads, including nausea and vomiting. Nausea and vomiting impair quality of life and can lead to metabolic imbalance and nutrition depletion. Acute delayed anticipatory breakthrough nausea and vomiting can happen. TDXT is highly emetogenic and SG with high-grade nausea and vomiting. In moderate emetogenic drugs, we can give in day 1 DEXA plus 5-HT3 antagonist and continue with 5-HT3 in day 2 and 3. In highly emetogenic, we should give 3 drugs, DEXA plus HT3 antagonist and NK1 antagonist, and continue with NK1 antagonist in day 2 and 3. Breakthrough fever should be managed by metoclopramide. Refractory nausea and vomiting olanzapine is very helpful. Anticipatory vomiting very important to treat acute and delayed vomiting. Anxiolytic drugs like lorazepam and relaxing measure can help to control anticipatory vomiting. Diarrhea mainly related to the release of payload before to the normal tissue. SG causes diarrhea in most of the cases with high grade 3 reaching 10%. TDM1 and TDXT have a low incidence to develop diarrhea. Specifically, diarrhea is high in SG because the active metabolite SN38 and the diarrhea is related mainly to topoisomerase 1 inhibitor that is included in the DXT and SN38. But in case of SN38, the patient having higher incidence of diarrhea because SN38 have particular and unique metabolism. It deactivated the liver, but unfortunately, the gut microbiota can reactivate it in the gut, leading to high grade of diarrhea, which is not the case with DXT, which is deactivated in the liver and not reactivated in the gut again. Managing diarrhea according to the onset. In case of early onset, atropine administration is very important. In case of late onset, loperamide should be started, and in case of failure of loperamide, short-acting octreotide is very helpful. Diarrhea with fever, antibiotics should be given if fever lasts for more than 24 hours or if accompanied with neutropenia. And not pharmacological therapies like taking soft diet, plenty of fluids, and avoid lactose-containing food. Oral mucositis, I will jump. Oral mucositis, liver toxicity is very common in patients receiving TDM1. 30% of patients, no guidelines for managing liver toxicity. But in case of grade 3 elevation of ALT or AST or bilirubin, the treatment should interrupted and reduced to less than grade 2 after recovery to normal. Interstitial lung disease is very important side effect in case of ADC. maybe idiopathic or triggered by other factors like viral radiation exposure. This is the risk factor. Maybe asymptomatic or having one or more symptoms. The patient may have abnormal blood gases or deterioration in respiratory function test. Radiologically, we can see different pattern of interstitial lung disease. It may be unilateral or bilateral. The most aggressive is the diffuse alveolar damage in the upper picture. Organizing pneumonia can be like organizing pneumonia, hypersensitivity pneumonitis in the third picture, or non-specific interstitial pneumonitis. Can lead to several complications ending with cor pulmonale and death. It is the diagnosis of exclusion, and this is very important. The patient should be evaluated for symptoms, careful examination, do physical examination, imaging to rule out other causes of lung symptoms. TDXD has higher incidence to do disease. We have to create synergy, to create multidisciplinary, so the whole drug if the patient is suspected to have interstitial lung disease, and steroid has a very important role in managing. This is an example of patient having lung cancer with HER2 positive treated with TDXD. After 2 weeks, he developed interstitial lung disease, and when receiving 4 weeks of IV methylprednisolone, he had marvelous response. Peripheral neuropathy is reported. The main important thing to control pain with several factors. Strong evidence that physical exercise, cryotherapy may help. Ocular toxicity also can be seen. TDM1 especially have particular ocular side effect because it is excreted in the tears, leading to lacrimal duct stenosis that requires surgeries at some time. It's important for the physician to be aware for this ocular toxicity, to monitor and manage it as a good time. Alopecia can also occur, rash, fetal toxicity. It's not, there's no evidence that it is safe to give in pregnant women. They are ADCs have fetal toxicity. Mother study is a prospective observational study, including patient pregnant or up to 7 months after conception receiving anti-HER2 treatment. And the result of this trial will help to assess the safety of trastuzumab in pregnant females. Potential strategies have been tried to minimize side effects by understanding the mechanism of toxicity. These strategies include dose optimization strategy, drug engineering for the antibody or the conjugation, pharmacogenomics for better selection of the patient and the dosing. To conclude, the rates of disease made a great breakthrough in cancer treatment, overcoming a challenge, the mechanism of underlying adverse effects, the pharmacokinetics, and the drug resistance need comprehensive comprehension. Awareness and proper education are key to guide clinicians to timely and identify and the proper manage adverse event to preserve the patient safety and to avoid premature discontinuation or unneeded dose reduction. And thank you for your
to Dr. Abdelhamid. Now, the next speaker will be Dr. Rehan Foda. She will talk about transfusion medicine and breast cancer, the good, the bad, and the ugly.
I'll be talking about breast cancer and transfusion medicine, the good, the bad, and the ugly. Breast cancer is most common female cancer globally, with approximately 20% of patients eventually developing metastatic disease. Anemia is present in more than half of cancer patients. which is an independent prognostic factor for short and long-term adverse outcomes. Because this anemia increases in the advanced period of cancer and perioperatively in patients with solid tumor who undergo surgery. Blood component therapy is an indispensable treatment in cancer. Over 85 million units of packed RBCs are transfused globally, and up to 15% of the transfusion resources are used by the oncology services in the USA. Now let's talk about transfusion medicine in a good way. So the causes of anemia in cancer patients include if there is any intratumor bleeding, intrahumeral bleeding, if there's generalized bleeding, or it could be due to chronic inflammation, nutritional deficiencies, hemolysis, GIC. It's particularly common in hematological malignancies, and anemia is also very common due to chemotherapy and radiation therapy. Also, blood loss perioperatively is a very important cause of anemia. Also, thrombocytopenia and coagulopathy in cancer patients include chemotherapy, radiotherapy, hematological malignancy, and TIC. So, we can say that indications of the blood transfusion in oncology can be broadly divided into four scenarios. A perioperative oncology patient with a curative intent, anemia in a patient with hematological or solid organ malignancies who requires blood transfusion for cure, if there is any acute massive hemorrhage or an emergency, and chronic severe anemia in a patient with palliative intensive care. These are, in short, the guidelines of blood product transfusions. These guidelines are basically by the Association of Advancement of Blood and Biotherapies. It released guidelines in 2016 regarding the RBCs, in which transfusion is indicated in hospitalized stable anemia of about 7 grams per deciliter. In patients undergoing major surgery, it's indicated when the hemoglobin is 8 grams per deciliter. And if the patient has a history of cardiovascular disease, we give blood transfusion at if it is less than 8 grams per deciliter. As regards platelets, the same association released guidelines in 2015 in addition to the ASCO guidelines, which have different indications for platelets according to the problem the patient has. For example, the cutoff for platelets in patients with hematological malignancies or undergoing cell transplant or solid tumors is less than platelets less than 10,000 per microliter. As regards the patients undergoing lumbar puncture or major surgeries, it could rise to about less than 50,000 per microliter. And for bone marrow aspirations and biopsies and insertions of CVPs, we might have to give platelet transfusion at less than, if the patient has platelet count of less than 20,000 per microliter. As regards to plasma, it is usually given or administered to patients who are suffering from coagulation deficiencies or in case of surgeries when we have to start a massive transfusion protocol. As regards of perioperative requirements in breast cancer, in cancer in general, the perioperative packed RBCs transfusion is generally high. And it differs from cancer to cancer. For example, it's about 9.4 to 55.5 in lung cancers. It's about 14 to up to 83% in breast cancer, and 7 to 40% for prostate cancer, and 60 to 90% for colon cancer. There are certain literature that even go on as much as to say that the requirements for breast cancer can reach up to maybe less than 2.1%, perhaps 3.4%. So there's a wide range between the requirements of perioperative requirements of breast cancer patients for blood transfusion. Given these numbers, they reflect the lack of consensus on triggers of blood packed RBCs for transfusion with cancer. So many people cannot agree what are the exact triggers of blood transfusion. And it was also noticed that blood transfusion was linked to a decrease overall survival in breast cancer patients. We have the available evidence that regarding the perioperative blood and blood transfusion impact in cancer. For example, there is no association regarding cervix cancer or metastatic metastasis in the lung bones or spinal metastasis. However, there is conflicting evidence regarding hepatobiliary carcinoma, bladder cancer, and ovary cancer, and it was shown that blood transfusion can have a negative impact on gastric cancer, esophageal cancer, and as you can see, breast cancer. So talking about the need for blood transfusion in breast cancer, especially in patients receiving chemotherapy. In a study by Dr. in 2023 on 104 newly diagnosed breast cancer, they showed that the pre-chemotherapy level in breast cancer patients was in about 60% almost normal, and more than 30% they had mild anemia. And around 30% of the patients required red blood cell transfusion, with more than half of the patients requiring 1 unit and about 40% requiring 2 units. And blood transfusion has been shown to show statistically significant improvement in fatigue and breathlessness among palliative breast cancer patients after blood transfusion. They also have been provided a rapid response to anemia related to symptoms, improving the patient's overall performance and quality of life. And using a restrictive transfusion strategy, which is giving blood transfusion to for a patient who is less than 7 grams per cent, rather than above that, was associated with reducing blood utilization without increasing the perioperative morbidity and cancer-related morbidity. They also showed that a decline in hemoglobin was expected among blood cancer patients undergoing chemotherapy, regardless of their stage of cancer, age at diagnosis, pre-treatment hemoglobin, or types of chemotherapy or concomitant radiotherapy and hormonal therapy. So we have to expect that any patient with breast cancer will have an anemia at any stage or at any time during this. Since the cancer patients are at risk of developing cancer-induced anemia, we have to identify the mild anemia as early as possible and initiate oral iron supplement therapy to replenish the iron stores. We can use transfusion alternatives, and they have proven to improve the hematopoietic response during chemotherapy while minimizing the risk of allogeneic blood transfusion. Parenteral iron was used in combination with erythropoiesis-stimulating agents. And when compared to ESAs alone, they have demonstrated a significant hematological response. However, ESAs, they are controversial in terms they may cause thrombosis, so they are thromboembolism and tumor progression. So they're only recommended for palliative patients with hemoglobin less than 10 grams per deciliter. Now let's talk about that side of blood transfusion. Of course, we're talking here about the adverse reactions of blood transfusion. Since they are the most frequent preventive procedures, however, they have substantial risks. And approximately 1% of transfusions result in a potentially life-threatening adverse reaction. Of course, transfusion reactions vary in severity and etiology, and they include allergic and anaphylactic reactions, febrile, non-hemolytic reactions, septic reactions, citric acid overload, and inflammatory lung reactions. This is a table that shows the different signs of symptoms of different adverse reactions. For example, fever is more common in febrile hemolytic transfusion reaction, which was shown to be due to release of cytokines from the donor blood. Hemolytic transfusion reaction, which is due to incompatible blood. Septic transfusion reaction, which was implicated more with platelet transfusions. And transfusion-related acute lung injury was implicated with plasma components due to HLA antibodies. Maybe this has caused that blood banks nowadays, they will discard plasma from donors, from female donors who have been previously pregnant, so as to prevent trial from occurring to the recipient. Also, transfusion-associated graft versus host disease is common in more hematological malignancy. Another symptoms such as rash and pruritus occurs in transfusion-related allergic reaction, where the recipient has an allergic reaction to proteins in the blood component, or rather in the plasma component. Also, it may occur with transfusion-associated graft versus host. This also is another symptom which occurs with anaphylactic reaction, especially in patients who have IgA deficiency and receive plasma components that contain IgA. And again, naturally, transfusion-associated circulatory overload, especially in old patients who have cardiac insufficiency or inefficiency, and transfusion-associated dyspnea and air empty. And finally, hypertension, which occurs in with transfusion reaction, sepsis, acute lung injury, allergic reaction, and hypotensive transfusion. Of course, the most effective strategy in preventing any transfusion reaction is reducing the number of transfusions administered. And each blood transfusion should be clinically indicated. We should not depend on the hemoglobin as the only trigger to provide blood packed RBCs to the patient. So, safe administration of blood transfusion requires effective communication and collaboration between the transfusion services, the healthcare providers, and the nursing staff. And also, we should try a restricted approach to perioperative blood transfusion, especially in microvascular breast reconstruction. Thus, we can prevent, they have been shown to help and avoid increasing post-operative. Now we come to the IT side. Giving blood transfusion deliberately and without clinical cause can cause trigger some negative impacts in the patients receiving the blood. And since in some cases there are absence of evidence-based guidelines for transfusion, the transfusion practices will vary from different oncology centers. And the latest AABP guidelines for transfusion set the transfusion threshold between 6 and 9, depending on the clinical judgment, and this led to arbitrary transfusion practices rather than physiological necessity-based transfusion. There is also a debate regarding the age of the red blood cells, the effect of the age of the red blood cells on the patient outcome, and there are still clinical trials addressing this. The TRIM, or the transfusion-related immune modulation, is a complication associated with administration of blood component therapy. It was noted that there is a decreased immune surveillance as a consequence of transfusion packed RBCs, which there are residual viable leukocytes, apoptotic cells, and various biological responses that have been linked to cancer recurrence and progression. In terms of platelets and microparticles and fresh frozen plasma, they were shown to likely stimulate tumor growth and spread. There's also increasing evidence that activated platelets may promote metastasis. And we're talking about the platelets that are transferred to the patients. So they promote metastasis and proliferation of cancer cells, while cancer cells, on the other hand, also induce more platelet activation. So we have a vicious circle of interaction between the activated platelets and the cancer cells, and it is harmful for the prognosis of cancer patients, and it has been shown to cause increased tumor recurrence and decreased 5-year survival. This is the mechanism of cancer progression from packed RBCs transfusion. As we can see, we have the TRIM arm, in which the RBC storage regions, the residual leukocytes and cytokines reduced from the white BCs, and the cell-derived microparticles will lead to decrease the interleukin-2 and T helper cells, decrease the natural killer cells, increase interleukin-10 and the Tregs, and thus it will cause immunosuppression. And on the other arm, which is the non-TRIM arm, which is due to the RBC storage regions and residual cytokines, which will increase inflammatory cytokines and create hemoglobin, and all this, both arms will lead to calcium drop and dissemination. Some studies regarding blood transfusion rate of tumor recurrence in gynecological cancers have shown a higher risk of distant metastasis and decreased overall survival in cervical cancer treated with radiotherapy and receiving blood transfusion. In another study on 130 patients, it was shown that there was a difference in survival in primary radiation therapy for cervical cancer to receive blood transfusion. Also, there was an association and a poor outcome and perioperative blood transfusion was documented in advanced ovarian carcinoma with recurrence and mortality, case mortality adjusting for age and tumor rate. Another surgical, in surgical context, there was a 5-year survival rate for was when we compared between the autologous blood transfusion and allogenous and untransfused patients, there was it ranges between 90.9% in the non-transfused patients, allogeneic autologous blood transfusion, and decreased in 88% in untransfused patients and 81% in patients receiving allogeneic perioperative lung transplant. Paradoxically, in the context of breast cancer, immediate who receive labs for breast reconstruction, the perioperative blood transfusion does not seem to be an independent risk for metastasis or cancer recurrence. This concludes that the association between perioperative blood transfusion and the negative outcome in patients with cancer is not consistent across all malignancies. It seems to be of importance in the GIT, head and neck, and urological malignancies, and less pronounced in breast and gynecological and prostatic tumors. Also, it causes confusion to us because it's not dependent on just one factor. There's an interplay between the donation association factors, recipient characteristics, inflammation, infection, coagulation. We're even talking about the plasticizer in the blood bags that contain the blood or the plasma. All these are different factors that may cause recurrence of or may play a role in the recurrence of the cancer. We have to, cancer patients are often offered acquired blood transfusion therapy during the course of the illness. The decision for transfusion of blood products should be based on correct physiological knowledge and principles and assessments of the patient's risk factors. We should implement safe transfusion practices to ensure good outcomes in this patient. And since blood is a very valuable healthcare resource, and clinicians should have the knowledge of the potential risk and complications of blood intervention, as well as the ability to properly identify the patients most likely to benefit from such interventions. Thank you.
Professor. Thank you, Professor Mirhan Fouda, for your elegant talk. Now we are going to present Professor Dr. Amani Hilal. It's an honor for me to present her. To talk about CD4, CD6 inhibitors in advanced breast cancer.
Good afternoon, everyone. Thank you for being patient with us for this long session. And thank you for the university team for giving me the opportunity to be with you. And this presentation, thank you for the introduction. Now the presentation is about CDK4/6 inhibitors and advanced hormone receptor positive, HER2 negative breast cancer. This is the outline. This is the outline of the presentation. Advanced hormone receptor positive, HER2 negative, advanced breast cancer, and group of CDK4/6 inhibitors in this subset of patients, and the outcome from the CDK4/6 as an overall survival, efficacy in young patients, efficacy in endocrine resistant cases, and what is the role of the CDK4/6 inhibitors after progression on the treatment with the CDK4/6 inhibitors. Some facts we should all agree on. The hormone receptor positive breast cancer patients represent the most common subtype of the breast cancer, about 60 to 75%. And the all guidelines and the backbone for the treatment of advanced hormone receptor positive HER2 negative breast cancer is the final treatment, except in patients for visceral crisis. However, even this subset of patients now can be treated with some sort of endocrine treatment. And up to 50% of hormone receptor positive patients with metastatic disease develop mechanism of therapeutic resistance when they are treated with the single agent hormonal treatment we all know about. So this was the research point to start trying to overcome the resistance developed to hormonal treatments by combining targeted and anti-estrogen therapies to overcome such a resistance to hormone receptor loss disease. And one of these drugs that have been invented to be combined with hormonal treatment is the CDK4/6 inhibitors, which cause the arrest of the cell cycle, preventing the cell from passing from the G1 to S phase and causing apoptosis. This is very short. There are a breakthrough in the hormone receptor positive treatment of the breast cancer, starting from the tamoxifen in 1980s, then was to the gestrol acetate, the aromatase inhibitors in 2002. Then 10 years later, start to have some target therapy to overcome the endocrine resistance, starting with the virologous exemestane, and then 3 years later start the CDK4/6 inhibitors, and the passing till now the PI3 mutant drugs. And the antibody drug conjugate that has been beautifully introduced by Professor Ahmed Bastawisi and Dr. Abdul Hamid. These are the phase 3 CDK4/6 inhibitor clinical trials that we own. There are 3 CDK4/6 inhibitors approved for the treatment of breast cancer: the valprocycline, the abemaciclib, and the ribociclib. And there are 3 groups of trials testing these 3 drugs, either as a first line or a subsequent line in the postmenopausal patients, and some or only Nagisa 7 before the premenopausal. However, the premenopausal was reported in some of these trials, and the combination with aromatase inhibitor or with fulvestrant. Overall, the survival is an ultimate goal. The improvement in the overall survival were not observed among patients with metastatic breast cancer through 2013. This is the problem. We don't have an overall survival advantage, and this led to the use of the progression-free survival and overall response rate as the endpoints for the trials in the treatment of metastatic breast cancer. However, the key goal in the treatment of the metastatic breast cancer is to prolong survival, with an emphasis on restricting treatment-related toxicity as much as possible. Of course, the need also to time to disease progression is increasingly used as primary endpoint. However, the overall the survival is the key or the goal endpoint that we should all use in the clinical trials for the treatment of metastatic breast cancer, and this was stated by the FDA. Overall survival is considered the most reliable cancer endpoint, and when studies can be conducted to adequately assess survival, it's usually the preferred endpoint. Now, these are the CDK4/6 inhibitors in the first-line trials, and all showed the significant improvement in the progression-free survival by about 10 months for all of the trials, whether the abemaciclib or the valprocyclib or the ribociclib. However, both the overall the survival for there are 3. I will start with the first line CDK4/6 inhibitor trials for the Baheya 2, Nagisa 2, and NARS. The 3 trials included the postmenopausal patients who developed the metastasis more than 12 months after ending the adjuvant treatment, or those presented with de novo breast cancer metastasis, or in other words, for the endocrine sensitive disease. For the Baheya 2 trial, there is no evidence of the improvement in the overall survival. And for the NARS-3, there is numerical improvement in the overall survival. However, it's not reached the pre-specified boundary for considering it as a significant, while for the Nagisa 2, there is significant improvement in the overall survival. For the 3 trials of the first line, the CDK4/6 inhibitor was combined with the aromatase, non-steroidal aromatase inhibitors. For the Nagisa 2, the median overall survival for patients who received the ribociclib was the 63.9 months, more than 5 years, compared to 51 months, improvement of about 1 year when using the single agent hormonal treatment. And this improvement in the overall survival, the difference between the using the ribociclib in the combination with the endocrine treatment versus single agent is increasing over time, starting by 5.7% in the first 4 years, and now the difference is 12.2% at 6 years follow-up with the improvement of the overall survival. Passing to the post-AI trials, whether the using after the aromatase inhibitors, the Paloma 3, Monarch 2, Monalisa 3, and Monarch 1. Monarch 1 is single agent abemaciclib. For the Paloma 3, Monarch 2, and Monalisa 3, the combination of the CDK4/6 inhibitors is with fulvestrant, not aromatase inhibitors. And again, the 3 drugs give significant improvement in the progression-free survival, although the benefit is slightly less than that of the first line, but still there is significant improvement in the progression-free survival. This is the Paloma 3, included the patients after the progression on the previous line of the endocrine treatment or previous line of chemotherapy for metastatic disease, and the addition of the palbociclib with the fulvestrant, although improved the progression-free survival within to the overall survival. For the Monarch 2, combination of the abemaciclib and the fulvestrant improved the median overall survival to about the 9 months, 46.7 months versus 37.3, and this was a significant improvement in the overall survival. For the Monalisa 3, and the Monalisa 3 has two subset of the patient population, whether used as first line for the patient either removal of those relapsing after 12 months completing adjuvant treatment, and another type of population, those who progressed on the first line endocrine treatment, treatment, or they progressed to less than 12 months of the adjuvant treatment. For the whole population, there is a significant improvement in the overall survival, with the median overall survival of about the 54 months versus the 42 months for those who didn't receive the ribociclib treatment. And this overall survival benefit was maintained in the first line and second line, although it was pronounced in the first line, but still there is significant improvement in the overall survival with the use of ribociclib in the second line. So when we want to summarize all the trials using the valco and abemaciclib and ribociclib as regarding the significant overall survival benefit, there is an improvement of the overall survival for the Monalisa 2 for ribociclib, and the abemaciclib, although there is a numerical difference but not statistically significant, and for the Monalisa 7, Monalisa 3, and the Monarch 2. To summarize, giving the CDK4/6 inhibitors with the hormonal treatment resulted in significant improvement in the overall survival with the ribociclib in all the trials, whether used as the first line or second line. While in the abemaciclib, the addition of the mainly fulvestrant with the abemaciclib resulted in significant improvement in the overall survival, but not with the aromatase inhibitor as first line, and the palbociclib, unfortunately, no improvement in the overall survival had been observed with the combination with either aromatase inhibitor or with the fulvestrant. When trying to define which group of patients would benefit more from the addition of the CDK4/6 inhibitors to the hormonal treatment, in the Monalisa trials, all patients with the visceral metastasis improved with the addition of the ribociclib, and the same with the abemaciclib, and abemaciclib, especially those with single liver metastasis. And there is no improvement in the Paloma trials except for the non-visceral disease. For this abemaciclib, the improvement was pronounced in the visceral but not in the bone-only disease. However, the ribociclib demonstrated clinically meaningful survival in the benefit in the patients with the visceral metastasis. Now going to a very important subgroup of patients, the young or the premenopausal patients. Premenopausal breast cancer is the most frequently diagnosed cancer among women worldwide. We all know this fact. It is the most common cancer diagnosed in the females. And the premenopausal, those younger than 50 years of age, are a higher proportion of patients in Asia Pacific and Middle Eastern regions, and about 2/3 of the premenopausal women with breast cancer have the hormone receptor positive HER2 negative disease as the most common subtype of breast cancer. And compared with high-income countries, patients in low and middle-income countries are more frequently diagnosed at an advanced stage, and the premenopausal patients with the metastatic breast cancer tend to have more aggressive and the poorer prognosis than those with the disease in older patients. The first trial that has been only confined to the premenopausal patients is the Baheya 7. This is a phase 3 randomized double-blind placebo-controlled trial involving the pre and the perimenopausal women with hormone receptor positive HER2 negative, no prior endocrine therapy for advanced disease. However, the one line of chemotherapy is allowed before introducing to the trial, and the patients with the no previous line or the first line treatment is also allowed. Patients were randomized to receive either ribociclib plus the tamoxifen or non-steroidal aromatase inhibitors versus the placebo plus tamoxifen and non-steroidal aromatase inhibitors. As I've shown you before, the progression-free survival is significantly improved. For the overall survival, the addition of the ribociclib for the whole group of the treatment population, the ribociclib plus the final treatment result in overall survival of the 58.7 compared to 48 months for those who didn't receive the ribociclib in the treatment. So there is an improvement of about more than 10 months. And this improvement is more pronounced in younger patients. Patients younger than 40 years showed the improvement of about more than 11 months in the median overall survival. Prolonged overall survival with relative reduction risk of death, about 35% for those younger than 40 years. However, there is still improvement in the patients older than 40 years, about reduction in the risk by the 19%. Now going to the other trial, right choice study, and we were sharing involved in this trial, and the principal investigator is Dr. Ahmed Bastawisi. This trial did something which is not usual. She included young patients with a very aggressive disease and dared to study the population of CDK4/6 inhibitors plus the hormonal treatment for treatment of such patients, while in our practice, when we are meeting premenopausal patients with a very aggressive disease and rapidly progressive impending visceral crisis, we are not even thinking about the hormonal treatment. We are only thinking about chemotherapy, and not only chemotherapy, combination chemotherapy. So look to the design of this study. Hormone receptor positive HER2 negative advanced breast cancer, very old premenopausal women, age 18 to 59, no prior endocrine treatment or chemotherapy for the advanced disease, performance status less than or equal to, and total bilirubin is less than or equal 1.5, with symptomatic visceral metastasis, rapid progression of the disease of impending visceral compromise, and markedly symptomatic non-visceral disease. So very aggressive disease, randomized in 1:1 ratio to ribociclib or none and plus the non-steroidal aromatase inhibitor, of course with LHRH, versus the investigator choice of combination chemotherapy, docetaxel plus capecitabine, paclitaxel plus gemcitabine, or capecitabine plus vinorelbine, very effective combination chemotherapy versus the hormonal treatment, and the endpoints. The progression-free survival, this is the primary and secondary clinical benefit rate, overall response rate, overall survival, time to treatment failure, safety, and tolerability. And these are the definitions of the visceral crisis according to the ISO and ISO guidelines, where there is the severe organ dysfunction as assessed by signs and symptoms, laboratory studies, and rapid progression of the disease. Visceral crisis is not the mere metastasis, visceral metastasis, but implies important visceral compromise leading to clinical indication from a more rapidly efficient therapy, particularly since another treatment option at progression probably not possible. And this is the definition for the indications for patients involved in the right choice study. And the first line ribociclib plus endocrine treatment achieved a statistically significant progression-free survival benefit of about 1 year over the combination chemotherapy in aggressive hormone receptor positive HER2 negative advanced breast cancer, with median overall survival of 24 months versus 12 months for the combination chemotherapy. Very impressive. Time to treatment response and objective response rate, and this is very important. You are dealing with a patient with aggressive disease, with the rapidly progressive symptomatic, so we need to know if the use of the endocrine treatment will be equal to the combination chemotherapy relieving such symptoms in the same time. And it has been shown that the ribociclib plus the endocrine treatment showed the improvement of type 2 treatment or clinical benefit rate in the 66% versus 60%. This is the overall response rate, and the clinical benefit rate of 80% versus 72% for the combination chemotherapy. And median time to treatment relapse with the ribociclib and the endocrine treatment was similar with the combination time to response. So the time to response is about the 4.9 months, and the for ribociclib at 3.2 for the combination chemotherapy. So you need a very rapid active drug to control the disease. It was equal between the hormonal treatment and the chemotherapy, and the overall response rate and the clinical benefit rate were comparable between the both lines of the treatment. Also, time to treatment failure and 3-month treatment failure was the higher for the ribociclib and the endocrine treatment when compared with the combination chemotherapy. Also, the use of the ribociclib and the endocrine treatment showed the benefit again more in younger patients than in the older patients. The reduction in the disease progression was higher among the patients younger than 40 years, with median progression-free survival not reached versus 10 months for the combination chemotherapy. There is also benefit in the older patients, but the benefit is not that pronounced as in the younger patients. Also, the same applied for the overall response rate and the clinical benefit rate. For the safety profile, the safety was consistent with Baheya trials. Nothing is more for this subset of patients, and the grade 3 toxicity in the hormonal treatment was only 1 versus the 7% for the combination chemotherapy. Of course, the treatment-related the grade 3 toxicity was higher among the combination chemotherapy. So now we're having an effective endocrine treatment for patients who suffered from the progressive disease with the effect in the duration, which is equal to that obtained by the combination chemotherapy, and the higher progression-free survival and better safety profile. Waiting for, of course, the updated analysis. Now, for the endocrine resistance, and this is a big problem for the workers in the field of the breast cancer. Primary endocrine resistance, as we all know the definition, is the relapse within the first 2 years of adjuvant endocrine treatment or progressive disease within the first 6 months of the first line of endocrine treatment for advanced breast cancer while the patient is on endocrine treatment. For the secondary or acquired endocrine resistance, relapse while on adjuvant endocrine treatment after the first 2 years, or relapse within 12 months of completing adjuvant treatment, or progressive disease more than or equal 6 months after initiating endocrine treatment. Of course, endocrine resistant is the against this, meaning the relapse after 12 months of completing adjuvant treatment. These are the trials including the endocrine sensitive disease only Monarch 3, Paloma 2, and Mona Lisa 2, while the endocrine resistance primary and acquired in Monarch 2 and Paloma 3 and other Mona Lisa 7 and 3 included the both subgroups, endocrine resistant and endocrine sensitive. In the Paloma 3 trial, there is a significant improvement in the overall survival for the patients who presented with the endocrine sensitive, but not in the patients with endocrine resistant disease. In the monarch, there is the improvement overall survival with the patients with the primary endocrine resistance and secondary endocrine resistance, and the same applies for the Mona Lisa for the ribociclib, where there is significant improvement in the overall survival among the patients with the endocrine resistance and endocrine sensitive disease. Now, the impact of CDK4/6 inhibitors on quality of life and safety, which is very important for patients with advanced disease. This is the first line trial, the toxicity. We all know that the toxicity for valprocyclib and the ribociclib are the hematological toxicity with the neutropenia, while the main toxicity of the abemaciclib is the diarrhea. The adverse events occurring with ribociclib are usually asymptomatic, tend to occur early and decrease over time. So starting with most of the side effects are usually observed with the beginning of the treatment, and these usually decrease with the time as the patient is on the treatment, and the neutropenia leading to discontinuation of the permanent discontinuation of the treatment less than 1% of patients, 4% for the inhibition of the liver enzymes, and the QT prolongation less than 1% of the patients require permanent discontinuation of the treatment. Across all the Mona Lisa trials, ribociclib-based combinations induced rapid and sustained reduction in pain, and this is very important for patients with advanced disease. This is the summary of the quality of life from the 3 trials of the CDK4/6, and as you can see in the Mona Lisa trial, there is always the improvement in the health-related quality of life with the significant reduction in the pain related to the disease. Across the Mona Lisa trials, addition of ribociclib lead to maintained or improved overall survival. In Mona Lisa 2 and 3, among the post-proposal patients, there is maintained health-related quality of life, while in the Mona Lisa 7 for young patients, there is improvement in the health quality of life compared to the poly-endocrine treatment. Now, the question that has been asked, what after the progression on the CDK4/6 inhibitors? We have 3 CDK4/6 inhibitors, and the fact that they are the same drug, they are not, they are different in the pharmacokinetics and pharmacodynamics, and even in the outcome of the treatment. So it comes to the surface, what have, if there is any room for CDK4/6 inhibitors after progression, and this is the phase 2 maintain trial, addition of ribociclib to endocrine treatment after progression on the CDK4/6 inhibitors plus endocrine. Men or women aged more than 18 years of age with hormone receptor positive, more than equal 1% in the score, HER2 negative metastatic breast cancer with progression in endocrine treatment, and any CDK4/6 less than equal 1 prior line of chemotherapy for metastatic, meaning patient not receiving chemotherapy, or 1 line is only allowed. Measurable or non-measurable disease with good performance status, and LHRH allowed for the menopausal women, and the stable brain metastasis is allowed for the inclusion, and the patients were randomized to receive either ribociclib and the switch the type of the hormonal treatment, not the same hormonal treatment given upon progression versus the placebo, and again switch the endocrine treatment. Fulvestrant as endocrine treatment if progression on the aromatase inhibitor for metastatic breast cancer, and no prior fulvestrant. Protocol amended to allow exemestane as endocrine treatment if progression on fulvestrant. So we can use either fulvestrant on the AI progression or exemestane if progression on fulvestrant. And these are the patient characteristics, where about the 78% of patients were previously treated with valprocyclib and endocrine treatment, and there is the improvement in the progression-free survival by about 3 months for the challenge with the CDK4/6 ribociclib upon progression and only switching the hormonal treatment. However, this point is still under investigation, and there are still some trials trying to answer this question. CDK4/6 could be beneficial after the progression on the previous treatment. The base trial with the valprocyclib and the immune therapy, the addition to immune therapy, and the Baheya and post-normal trials. Now, this is the NCCN guidelines for the treatment of advanced breast cancer. It summarizes all what I have seen already about half an hour. For a first-line therapy, and when aromatase inhibitor is considered to be added to the CDK4/6 inhibitors, the guidelines say we have to use ribociclib as the one, and this based on the outcome or the results of the Unalisa 2 trial. And if the fulvestrant is added to the CDK4/6, then you can use either ribociclib or abemaciclib, and this is the category 1 for the subsequent treatment of patients after progression or as a second line. If the patient did not receive CDK4/6 in the first line, then you can use the hormonal treatment plus any of the CDK4/6 inhibitors. I just want to end my presentation with this post. And it's taken from the Professor Fatima Kuduzu. You all know about her. And she's an eminent figure in the advanced breast cancer. And now saying that the key objective of the advanced breast cancer conferences is to double the survival among patients with advanced breast cancer by 2025. And this is starting to happen. We have made a major step towards our goal of doubling average survival times for patients, because we have now achieved this in 2 or 3 subtypes of advanced breast cancer: the HER2 overexpressing, the HER2 positive, and the hormone receptor positive. She said that the improvement in the overall survival has been reported recently by the HR positive advanced breast cancer treated with cyclin-dependent kinase 4/6 inhibitor at ESMO Congress 2021. First-line treatment with ribociclib plus letrozole led to median overall survival of 63.9 months compared with 51 months with letrozole only, 24% reduction in the risk. And we now have a median overall survival of 5 years. For the first time, we can speak about hope for these patients, not just wishful thinking. That's all we need, is the hope and better outcome for our patients. Thank you for your patience. And
thank you, Dr. Amani, for this informative lecture. And now the last talk in this session will be by Dr. Ahmed Magdi, the story behind HER2 low disease.
Everybody, we're all tired, but I promise I will not take long. First of all, I would like to thank for allowing me to be their speaker today. So I'm going to tell you the story of HER2 low. Is there a story? Let's see. This is my disclosure for today. This is the agenda, and let's go about the expression of HER2. It was discovered that almost every cell in our body has HER2 in different concentrations. And then actually, it was discovered that most breast cancers, they do have HER2 overexpression, even in the triple-negative breast cancer. And then it was correlated that HER2 positive patients do have poor prognosis, as published before in 1987, which is a very good study showing us that HER2 overexpression is a bad prognostic index for breast cancer. Then again, it was discovered, and it was published again in 2021, that 55% of breast cancer are HER2 low. So what we thought before they were HER2 negative, 55% are HER2 low. Actually, they are more common in human breast cancer rather than triple-negative breast cancer. So what we got the idea is that triple-negative breast cancer, we should use the ADCs with them and find HER2. But actually, it is more with human subtype of breast cancer. And actually, they do have better overall survival. Better survival. And definitely, immunohistochemistry 2+ is worse than the 1+. Then we all heard about, we all know by heart, how the anti-HER2 or the trastuzumab have been working. Because if you see the HER2 receptors, they are activated either by the binding of the protein that stimulates their activation, or by ethyl glycylation with the underlying or the sideline HER2. Then this is why we have been using the trastuzumab and the pertuzumab in combination, which show the overall survival, whether in neoadjuvant pathological CR or the metastatic. And then we all know these are all HER2 approved by the FDA. But then the HER2 negative, this was the chart before. Most of our patients were HER2 negative. But then again, we overlooked the +1 or the low member in the staining +1, +2. Then it was discovered again the association with the estrogen receptor. So luminant patients, they tend to have more HER2 low expression. But then came the dilemma, how to define HER2 low? So is it a static definition or a dynamic definition? So static definition is very simple. Those with HER2 +1 or HER2 +2, they are HER2 low. But what about your patient when you start with him as HER2 +1, and then upon progression, you get HER2 negative 0, and then when you take another biopsy upon progression, he becomes or she becomes HER2 +1 or HER2 +2. So would you go with the static definition or the dynamic definition? Again, this is a very difficult question to answer. But then when we go to the NSABP famous trial that utilized the trastuzumab, if you look at the subgroup analysis, you find that HER2 negative were included and actually they were responding. So they started thinking how HER2 negative the patients were responding. Then if you look at the trial of the TDM1, TDM1 actually had some activity. If you look at the low curve with the HER2 negative, yes, it was the poorer progression-free survival, yet there was some sort of a response. So before we used to say HER2 negative, and then HER2 positive, then HER2 low. And actually, I would like to tell you that we're now facing the ultra low in the future. And I will give you a hint about that. What about the trastuzumab deruxtecan you've been hearing about? So it's an antibody drug conjugate, and the idea has been explained marvelously by colleagues. But if we compare the trastuzumab deruxtecan with the famous TDM1 that we have been using for a long time. So the payload, which is the chemotherapy payload with the linked to the antibody, is anti-microtubule in the TDM1. However, it's a topoisomerase 1 inhibitor for the trastuzumab deruxtecan. And actually, if you look at the drug to antibody ratio, meaning the concentration of the chemotherapy linked to the antibody, it's 8 to 1 in the trastuzumab deruxtecan versus 3.5 to 1 for the TDM1. And actually, the idea behind the ADCs is mainly the payload and not the antibody itself, because HER2 is present, right? So it's, why the difference between the TDM1 and the TDXT? Because the payload is higher, the payload is more active. And actually, the tumor selective linker is, yes, mainly with the TDXT versus the TDM1. And then we discovered, as Professor Ahmed Ostowitsi showed us, that the bystander effect actually is a new modality of response. So when we give the antibody, it gets internalized, releasing the payload. Then when the cell dies, this payload actually transfers to the siding cell. So actually it kills the targeted cell and the bystander for the cell beside it. So if we look at the DESTINY-4 trial, comparing the trastuzumab deruxtecan versus physician's choice of chemotherapy, as you can see from the separation of the curve for the progression-free survival in hormone receptor positive patients, you'll see the beautiful separation of the curve. Actually, if you look here, you'll find the early separation of the curves. So you get an early response, early separation of the curves. And this is in hormone receptor patients, hormone receptor positive patients with an impressive hazard ratio of 0.5, meaning that 49% of your patient will achieve this response. And if you look at all patients known hormone receptor positive or hormone receptor negative, you'll find again this hazard ratio still maintained at 0.5 with again early separation curve. What about overall survival? I don't need to talk because you can see that you have gained almost 8 months of overall survival, 7 months of overall survival, and still has a ratio of 0.64. Again, in all patients, the same. What about the progression in hormone receptor negative, specifically the triple negative, as you want to say? You'll find that the hazard ratio is even better with a hazard ratio of 0.46. Again, early separation. What about this waterfall plot curve? You can see that the change of size, you'll find it way more with trastuzumab deruxtecan versus the chemotherapy. If you go through all the subgroup analysis, all were in favor of the TDXD. Progression-free survival and overall survival. What about if those patients who were more receptor positive? Because we mentioned that HER2 low is mainly more with the human subtypes. So definitely this lady has received the CDK4/6 inhibitor. Would this affect the outcome after the TDXD? Actually, no. For the progression-free survival, for those who received CDK4/6, they were actually better with the TDXD versus the chemotherapy. Even with no prior CDK4/6, you still get a benefit. So whether you put it before the CDK4/6 or after the CDK4/6, you definitely get a better response. What about those who received one prior line of chemotherapy? The response is still maintained. 1 or 2 or more, you get still a better progression-free survival. What about immunohistochemistry +1? As you can see, the hazard ratio of 0.47, meaning that 53% of the patients will achieve a response with the TDXD, and again, a hazard ratio of 0.54 with IHC. What about the 5 lines? We have the Destiny A trial combining the TDXD with multiple lines of therapy. And if you look closely at the second arm here, you'll find with the durvalumab, which is an immune checkpoint inhibitor and PD-L1. So basically, we are seeing in the future a combination, and maybe we can find a better outcome if we can go for that. And this is the waterfall plot for the combination. It was a phase 1 B2, the combination of durvalumab with the trastuzumab deruxtecan, and you can see that the size is impressive. What about the neoadjuvant? We do have an ongoing neoadjuvant using AI with trastuzumab deruxtecan, but we don't have any data yet. And don't forget, we do have in the pipeline many antibody drug conjugates regarding the HER2 low, like the SYD985 and the Baheya as shown before. What about the sacituzumab govitecan? When they showed us the data of the sacituzumab govitecan, which is an anti-TROP2, it was in the triple negative patients. However, it included those who used to go triple negative with HER2 low. So now you are facing the dilemma. For those HER2 low, should I go for sacituzumab govitecan or should I go for the trastuzumab deruxtecan? Time will tell us. We don't know this answer yet. So what about the ultra low? We heard about the ultra low. There is the ongoing trial, Destiny Breast 06. So at 1+, we used to say low, right? But then they discovered the subgroup where it is positive between 0 and less than 1+. So these are the ultra low, and there are ongoing trials for that. So we looked at the most recent NCCN guidelines, find that hormone receptor positive, HER2 negative, you get trastuzumab deruxtecan as category 1, sacituzumab govitecan also as category 1, and for now we don't know how to put them in sequence. If you look at the triple negative, if you get the BRCA mutation, we all know that you should use the olaparib, sacituzumab, and again, if you find HER2 1+ or 2+, you are allowed use the trastuzumab deruxtecan. And to conclude, we now know that triple negative is not one disease, it's now a heterogeneous disease act. And we cannot go and say triple negative as an absolute factor. We should look at the HER2 low because we now have target for them. And more data is very important needed to how to sequence our weapons that are present in the triple negative patients. And ultra low actually could be a very promising target in cancer. And thank you so much for this.
Thank you so much, Dr. Ahmed, for the very elegant, informative presentation. Thank you so much for the speakers and for the chairmans. Can we allow questions or out of time? Okay, Since we're out of time, thanks, Dr. Amani, for inviting me today in this very elegant conference. And now we will go to the next session. أنا آسفة.
عشان كده لو الصوت مش هيطلع
اكيد عادي عشان ما بيبقاش كهرباء. مين؟ دي مستنيينها. ولا هتمناك معايا بس هي رجعت من اول استني حد تاني هيتكلم ولا هي طالعه؟ ايوه انا ما هقدم لك حد الدنيا ناس كتير اهو. طب ايه؟ لا ما الدكتوره علا جت خلاص. ايه؟ يا سلام يا سلام. لا لا صوري ونوصل كمان. طلعينا معاكي. انا مش فاهمه ما فهمتش السؤال. انت يا عمر لا ما فيش. يا علا سلم عليها سلم عليها الاول.
بسم الله الرحمن الرحيم. إن شاء الله نبتدي السيشن دي. اتفضلوا. طبعا أحب قبل ما ابتدي طبعا أشكر الأورجنايزنج كوميتي، بشكر الدكتور أماني، ويشرفني طبعا إن أنا أقدم زميلتي الفاضلة الدكتورة علا خرشد. The title is about expanding the landscape of early triple negative breast cancer. اتفضلي يا دكتورة علا.
Well, first of all, يعني how proud I am to be here, and how proud I am of Dr. Amani Hilal and her amazing team. What she did in Baheya is beyond any. So, bravo, يعني. And thank you for inviting me to be one of your speakers. It's quite an honor. So let's talk about triple negative breast cancer patients in the early disease. We have a lot of challenges, and let's know first that the biggest challenge of triple negative breast cancer is that although it's present in only 15% of breast cancer patients, it's a disease mainly of the young. It's associated with BRCA mutation only in 20% of the population. However, you need to know that the biggest problem of this disease is that it is a highly proliferative disease. It develops very rapid resistance to chemotherapy, and the main important problem is that recurrence and metastasis, it does occur early. It's very frequent. Whenever you have a patient with metastasis, it occurs more visceral. And remember, brain metastasis can occur as high as 46%. Once a patient develops metastasis, the median survival is less than 2 years. We do have some indolent subtypes in the triple negative breast cancer, and these are mainly older females. Remember, adenoid cystic carcinoma is considered to be indolent. Now, why is it important to not treat triple negative as you treat all the other subtypes? So historically, when we used to treat patients with surgery and then giving adjuvant chemotherapy, if you look at the figures, so if you look at the survival according to staging, it is extremely lesser whenever you're talking about triple negative breast cancer. This applies to stage 1, stage 2, even in stage 3 disease. This is why we no longer go for surgery and followed by adjuvant treatment. What we do is that the standard of care now is that you have to give your patient neoadjuvant chemotherapy or neoadjuvant systemic treatment. We give neoadjuvant systemic treatment to all but your smallest tumors. So anything that's T1C or more, this you need to give neoadjuvant systemic treatment. Your main goal is to achieve a pathological CR, because we know that whenever a patient achieves a pathological CR that's triple negative, the 5 years event-free survival is 90%. Compare this to triple negative breast cancer, where you used to give just adjuvant treatment, and at 2 years, most of the patients had a relapse. And if the patient doesn't achieve a pathological CR, you need to be careful because the median survival of those patients is less than 9 months. Now, this is not the only reason that we're giving neoadjuvant treatment. Importantly, is to give adjuvant systemic treatment. And this adjuvant systemic treatment is individualized based on the response, and this is the hallmark of changing the treatment of triple negative breast cancer. So how can we achieve a very high pathological CR? This, we know that by adding taxanes to anthracyclines, the pathological CR is 30%. However, when you add carboplatin to the anthracyclines and taxanes, the pathological CR goes up to 53%. We've seen this in the brightness trial, where paclitaxel followed by AC and to add carboplatin or carboplatin and piperacillin. Whenever you add carboplatin, there is a significant improvement in the pathological CR, which translates to 4.5-year event-free survival that was significant. And this was confirmed in the Indian Tata Memorial Trial. This was a large trial, 700 patients. They had the 10-year follow-up for those patients, and you can see that patients who received carboplatin, who added carboplatin to their neoadjuvant setting, they were able to achieve a pathological CR of 55%. And this translated to an event-free survival. The boxes down there, you can see that the event-free survival increased by 34%, whether the patient was younger than the age of 50 or older than the age of 50. However, an important point that they were able to notice is that when you have a patient who is older than the age of 50, the benefit in terms of pathological CR is much less. Why is that? Probably because of the difference in the heterogeneity of the seed. Probably it's because it is more aggressive, or maybe because the patients were not able to tolerate the treatment. Now, this did reflect on the event-free and overall survival. You can see that if you add carboplatin to the neoadjuvant setting, you can have an event-free survival improvement by around 7% and an overall survival of around 7.6%. So this led to the question of asking, do we need to give anthracyclines or not? There is a minimal adverse event when you give anthracyclines, and most of the patients, they don't like having anthracyclines. Now, if you're going to be giving taxanes alone, do not do that. You need to give the taxanes and you need to give the anthracyclines. And this is the EBCCG data that was published quite recently. And you can see that by adding anthracyclines, you are having decreasing the recurrence from 27% to only 13.6%. However, when you compare removing anthracyclines with the new regimens, like when you are giving taxanes and carboplatin, in the ADAPT trial, in the pooled analysis that looked at docetaxel and carboplatin, in the new STOP trial, which looked at giving taxanes and carboplatin followed by AC, or just giving taxanes and carboplatin alone. In all of these three trials, there seemed to be no benefit from adding anthracyclines, so it seems that anthracyclines is no longer mandated. Now, the other important thing is we know that BRCA represents around 20% of our triple negative breast cancer patients. And there was a question, should we add PARP inhibitors in the neoadjuvant setting? And we've seen that adding talazoparib, this was a very small pilot trial where when the talazoparib, when given as a 1 milligram per day for 6 months, this drug alone was able to achieve a pathological CR in 53% of the patients. And this trial was expanded into a little bit of a larger pilot trial. It was multicentric, 61 triple negative breast cancer patients. Just by giving talazoparib alone, they were able to see a 50% pathological CR. Now, this trial was closed earlier because of, at that time, the immunotherapy started to appear. And the other thing is when they compared the pathological CR to what we achieved with the platinums, you can actually achieve the same pathological CR with much less cost, as you can see. And then there came the immune checkpoint inhibitors, using them in the neoadjuvant setting. And the rationale is that when you're giving chemotherapy, this overcomes the immune exclusion that we see in breast cancer. This results in antigen shedding. And what we need is rapid disease control, which we see when we combine chemotherapy and immune checkpoint inhibitors. So we have a lot of setups in triple negative breast cancer patients, whether we give neoadjuvant immune checkpoint inhibitors alone, and we have two trials, the GEPA-NUEVO and the NEO-TRIP trial, or to give the immune checkpoint inhibitors in the neoadjuvant and in the adjuvant setting. And of course, we have the practice-changing Keynote 522 trial, and then we have the GEPA-DOSE trial, and all. Shall we just give immune checkpoint inhibitor in the adjuvant setting? And again, we have several trials. So let me just start with the I-SPY trial. So the I-SPY trial was a small trial that showed that when you give 4 cycles of pembrolizumab in the neoadjuvant setting, added to chemotherapy, you can quadruple the pathological CR of the patients. And this led to the phase 3 Keynote trial, 522 trial. More than 1,000 patients were randomized to receive the standard of care, carboplatin paclitaxel, followed by doxorubicin, epirubicin, and cyclophosphamide. So this is the best chemotherapy that we have with or without pembrolizumab. And then the patient went for surgery. And then after surgery, the patient received 27 weeks of pembrolizumab, 9 cycles of pembrolizumab as adjuvant treatment. Now, pathological CR is 65%. By adding pembrolizumab to chemotherapy, your best chemotherapy is able to elevate the pathological CR by around 15%. And this was seen regardless of the PD-L1 expression. Now, this translated also to event-free and disease-free survival. This is interim analysis 4. So this was the most recent analysis, with an event-free survival of 8% improvement in the event-free survival and 7.5% in the distant relapse-free survival. And this was seen especially in patients who had high burden disease, lymph node positive disease, patients who had stage 3 disease. You can see that the delta for improvement in event-free survival was higher in the high bulk disease. And what was important in the Keynote trial is that whenever a patient achieves a pathological CR, look at the event-free survival. You can have more than 94% event-free survival at 4 years. Now, for those patients who don't achieve a pathological CR, giving pembrolizumab is actually doing much better than not giving pembrolizumab. You improve the 3-year event-free survival to 67% compared to 57%. So a 10% improvement in the event-free survival. And why is that? Because adding pembrolizumab to chemotherapy is actually decreasing the residual disease. So this is why we are having better survival. Now, what was also noticed that in patients who have a residual cancer burden 2, those patients were actually benefiting quite well from pembrolizumab compared to not receiving pembrolizumab. So despite having not achieving the pathological CR, patients receiving pembrolizumab, they still did improve, and you can see the significant improvement in event-free survival. Now, in Passion 031 was a trial that is similar design, where in patients who had triple negative disease, 300 patients were randomized to receive nab-paclitaxel with atezolizumab or nab-paclitaxel single agent, followed by EC, and then patients received maintenance atezolizumab again for 11 doses. There was a significant improvement in the pathological CR, 57%. With this regimen, there was numerical improvement in event-free, disease-free, and overall survival in early-stage disease. However, Roche withdrew the application, and it's not currently in the guidelines. Now, there are other IO studies where you give the neoadjuvant IO only without giving adjuvant immune checkpoint inhibitor. This is the Nuevo trial, which is looking at durva with nab-paclitaxel compared to nab-paclitaxel alone. And this study didn't have any adjuvant setting aside. So despite this particular trial, the pathological CR was quite modest, because again, the protocol was only nab-paclitaxel. They didn't have carboplatin in this protocol. And despite that, there was a modest, there was an improvement in the event-free, the distant disease-free survival, and in the overall survival. Again, this trial is asking the question, do we really need to give immune checkpoint inhibitor in the adjuvant setting? And then what about the new drug that we can use in the neoadjuvant settings, tislelizumab govitecan in the new STAR trial? This is a small trial, only 50 patients. It's a pilot trial, but then just by giving tislelizumab govitecan for 4 cycles, you are able to improve the pathological CR by 30%. And now there's an ongoing trial looking at adding tislelizumab to pembrolizumab, and we're waiting for that trial. Now, as I said, pathological CR is important, but what is more important is how can we tailor the treatment according to our response. So if you have a patient who achieved a pathological CR, do we need to give to de-escalate our treatment, or should we continue adjuvant treatment? And if the patient doesn't achieve a pathological CR, those are our worst patients. So what can we do for those patients? So should we continue adjuvant treatment, or perhaps we have better arms for those patients? Now, achieving pathological CR after chemotherapy, if you have a patient who achieves pathological CR after chemotherapy, is there any role for adjuvant treatment for those patients? Well, we've seen from trials and trials, and this is, I mean, look at this, whether you give adjuvant treatment or not, there's no difference in the event-free survival. And this was also seen in the ADAPT trial, where again in the ADAPT trial, they were giving adjuvant EC protocol after the patient achieved pathological CR, absolutely no difference in the event-free or the overall survival. Now, true that pathological CR, if your patient achieves a pathological CR, maybe we don't need to give adjuvant treatment. However, there's much more to it, because there are a lot of other prognostic factors in the triple negative breast cancer patient. You need to put into account the histological subtype, the grading, something such as the circulating tumor DNA. So if you can have a patient who has a pathological CR, yet they have circulating tumor DNA, and you can see that the recurrence is much higher if the patient is having circulating tumor DNA. So whether or not we need to give adjuvant treatment for those patients, something that we need to talk about. Now, what about giving a patient, such as in the Keynote 522 trial, who received neoadjuvant immune checkpoint inhibitor? Do we need to give post-neoadjuvant immune checkpoint inhibitors? Now, in the Keynote 522 trial, they did give adjuvant pembrolizumab, and you can see that the event-free survival was, as you can see, it was significantly higher. But we also saw with the Nuevo trial, this is a trial that didn't give adjuvant immune checkpoint inhibitor, and there were almost similar event-free survival. So the question is, do we really need to give for those patients who actually received immune checkpoint inhibitor and had a pathological CR, do we need to give immune checkpoint inhibitors? And for this, you will need to have to wait for the optimized pathological CR trial, which is they're asking this question. For those patients who received immune checkpoint inhibitor and had a pathological CR, should we give the patients adjuvant pembrolizumab or not? So this is going to be quite an important trial. Now, for those patients who don't achieve a pathological CR, the standard of care is to give capecitabine. We've known this from the CREATE-X, where we have seen an improvement in event-free and overall survival rate. Capecitabine was given as adjuvant treatment for those patients who had no residual disease. We have a 16,000 patients, and only by adding capecitabine we were able to see improvement in the survival. And this was seen mainly in patients who had non-basal subtype of the disease. What about giving immune checkpoint inhibitors to patients who didn't receive immune checkpoint inhibitors in the neoadjuvant setting? We have two trials that are asking this question, the eBrave trial and the Keynote 242 trial. However, if you have a triple negative breast cancer patient, it is so much wiser and better to give the immune checkpoint inhibitor in the neoadjuvant setting. Now, I told you that the Keynote 522 trial, the patient did receive adjuvant pembrolizumab, and you need to see, and I'm sorry about that, but I saw the slide and I took it as a capture because it showed that distant recurrence for the patients who had a RCP3 was much higher if you didn't give the patient adjuvant pembrolizumab. So for now, patients who don't have Keynote 522, we need to give the new adjuvant and you need to give the adjuvant setting. What about patients who had a BRCA mutation? The Olympia trial now is the standard of care for any patient having BRCA mutation. You need to give 1 year of adjuvant olaparib. You can see an improvement in the disease-free and in the overall survival. We do have newer trials that are asking, should we give adjuvant? What other better adjuvant treatment that we can give? So cetuximab in the Saskia trial is being investigated, and we're looking for this trial. So post-neoadjuvant treatment, this is what we have. If you have pathological CR and your patient has received pembrolizumab, you continue the pembrolizumab. This is the standard of care. The patient didn't receive neoadjuvant pembrolizumab, then you stop the treatment. For those who didn't achieve pathological CR and the patients have BRCA mutation, the standard of care is to give olaparib, capecitabine if the patient doesn't have the BRCA mutation, or continue pembro if the patient already received immune checkpoint inhibitors. And this is from Professor, this was presented in the last breast cancer, the St. Gallen breast cancer. And this is really just to, I'm putting the schedules that we have now for a neoadjuvant setting. Anthracycline taxane, adding the carboplatin, this is the second one, or even giving the pembrolizumab. And what are the standards of care? So if you have a patient receive vaccines and carboplatin and anthracycline, that you can add capecitabine or carboplatin for the BRCA wild disease. You have a patient who has BRCA, whenever you have a patient with BRCA mutation, olaparib is the standard of care. If you have a patient who received pembrolizumab and the patient has the adjuvant treatment is pembrolizumab, this is the standard of care. Now, there are a lot of trials now that are looking at combining pembrolizumab, capecitabine, and maybe olaparib for patients who have residual triple negative because they really do not do well. Now, this is the ESMO guidelines for treatment of early triple negative breast cancer. I simplified it into, if you have a very small disease, go for surgery. And if you have a patient with stage 1 disease, you can give something like just CC for 4 to 6 cycles. If it's stage 2 or 3 after surgery, then an AC followed a carboplatin containing regimen for 6 cycles can be given. If you have a patient that has at more than 2 centimeters or lymph node positive, those are high risk triple negative breast cancer patients. Go for the Keynote 522 trial. The patient that achieves CR, then pembrolizumab is the entrance. If the patient doesn't achieve a pathological CR, perhaps we need to look at trials that look at combining olaparib with pembrolizumab, or if the patient doesn't have a BRCA mutation, then pembro and capecitabine. And if the patient has something in between, then you give the new adjuvant treatment followed by capecitabine if the patient has residual disease. So we have improved the pathological CR by adding carboplatin, by adding pembrolizumab. Adjuvant treatment is standard of care. And really our unmet need is to know whether or not we need to escalate we need to have those trials that look at escalation of treatment or perhaps de-escalation in some patients. And with this, I thank you and invite you to the National Cancer Institute Congress, which is going to be in November, 30th of November to the 1st of December. Thank you.
Thank you very much, Dr. Aola. As expected and as usually expected, a very excellent and very informative lecture. Thank you very much. But can we just postpone questions for the end of the lectures because we are just beyond time? So if you don't mind, thank you.
First of all, I want to thank Professor Amani Hilal for her kind invitation to participate in this excellent and prestigious event. I have the pleasure to introduce Professor Luqay Qasim, Assistant Professor of Clinical Oncology, Cairo University, who will talk about optimizing adjuvant treatment of premenopausal patients with hormone receptor positive, HER2 neu negative early breast cancer.
Thank you, Mr. Chairman, for the nice introduction. I'd like to extend my thanks to Dr. Amani Hilal for the kind invitation, and again, to congratulate you all for the very nice meeting. Again, I'd like to thank you for choosing for me to speak among this very great, hand-picked group of speakers. Thank you very much. I will talk today about how to optimize adjuvant treatment for premenopausal patients with ER-positive, HER2 negative early breast cancer. These are my disclosures. And it started 120 years ago by an observation by many doctors who were treating cancer, breast cancer then. They were all surgeons. Medical oncology specialty was not there yet. So the observation was that some metastatic breast cancer patients had spontaneous disease regression. That's after cessation of menstruation. And because we all knew then that ovaries were implied secreting hormones, and by castration, that surgical removal of the ovaries, you could decrease the hormones and induce menopause. Dr. Beetson did publish his first piece of work on 3 patients with metastatic breast cancer doing ovariectomy. Doing that didn't break the cause, right? Doing surgical ovariectomy to patients with metastatic breast cancer. He observed disease regression in all the 3 ladies. One of them achieved complete remission. Why estrogen is implied in all that? Estrogen plus estrogen receptors are called transcription factors. So when combined together, they can act directly on the DNA, causing translation, transcription, then translation of specific proteins that are important in metastasis, in invasiveness, and in many of the carcinogenic traits. And that's why tamoxifen, the first anti-estrogen medication to be approved, did improve the disease-free survival and overall survival in patients with breast cancer when given after successful surgery. This is the Oxford meta-analysis, a very famous piece of information. Adjuvant tamoxifen saves around 40% of the recurrence and around 30% of the expected mortalities. That's adjuvant 5 years of tamoxifen. Again, chemotherapy do offer some benefit for young ladies with early breast cancer. If you did successful surgery and you did no chemotherapy, again, irrespective of the subtype, you have a chance of relapse around 50%. Adding adjuvant chemotherapy alone, and that's the CMF kind of chemotherapy, the very old chemotherapy, did save around 1/3 of those ladies. So you save 12 of every 100 from having a breast cancer recurrence, and you save 10 out of every 100 from dying from breast cancer. If you added anthracycline instead of methotrexate, you save additional 3 to 4 patients. If you added taxane, in addition to anthracycline, you save additional 3 to 4 patients. So, what is the problem with that? It seems that we're doing good. Actually, we're not. For this cohort of patients who are not doomed to have cancer recurrence we are giving overtreatment. And for those who are we giving taxanes, anthracycline, tamoxifen, we are under-treating, and they suffer cancer relapse and dying from breast cancer. How to improve that? Two main steps. First, to escalate, to add more therapy for those who are at higher risk of relapse, and to do less treatment for those who have lower risk of relapse. How to escalate? I have 3 advices for you. First, you use more effective endocrine therapy, more effective than 5 years of tamoxifen. I will cover that. More duration of endocrine therapy, what the so-called extended adjuvant endocrine therapy. That will be covered by one of the next speakers, Dr. Amira, and adding targeted therapy in addition to the current adjuvant endocrine therapy, and that will be covered by my colleague, Dr. Shayma, in the coming lecture. I will cover this point. Do we have a more effective endocrine therapy in the ER positive, HER2 negative early breast cancer? Yes, in the postmenopausal patients, again, the Oxford meta-analysis have shown us that aromatase inhibitor is slightly better than 5 years of tamoxifen in terms of the long-term disease-free survival and overall survival. However, you cannot do that in a premenopausal patients. So here comes the soft and text studies that did test 3 possible options of adjuvant endocrine therapy. So those are around 3,000 patients with premenopausal patients, like the situation that we're talking about today, and they're randomized to one of 3 options. First, tamoxifen alone. That's the Oxford meta-analysis option. Second, ovarian function suppression. That's the Dr. Beatson surgery, or of surgical removal of the ovaries, or you can do the LHRH depot injections, or to a lesser extent, you can do radiation. Ovarian function suppression plus the same good 5 years tamoxifen. And the third option is ovarian function suppression plus aromatase inhibitor, the expected more effective. The text study is another randomized study that did randomize patients to one of the last 2 options. So when we're comparing tamoxifen versus aromatase inhibitor in patients who are receiving ovarian function suppression, you can pool the results of the soft and text studies. This is the primary endpoint, the disease-free survival. You can see that there is some difference as early as 5 years after randomization between the blue one, that's the ovarian function suppression plus exemestane, the red one, the ovarian function suppression plus tamoxifen, and the last one, that's tamoxifen alone. Again, there is significant difference. The 5-year is 90% the good arm, the exemestane arm, 88% in the tamoxifen plus ovarian function suppression, and 86% in the tamoxifen only arm. Well, that doesn't look like very promising. However, wait to see. In ER positive, HER2 negative patients, we know that some patients are really not going to relapse. Many of them, the very low risk patients. Those patients in the soft and text study, they were deemed low risk, even not to offer adjuvant chemotherapy. So this cohort, the low risk cohort, were not receiving chemotherapy. 90% of them were more than 40 years old. The majority of them were not negative, small tumor size, and grade 1. What happened to this comparison? You can see, without looking at those numbers, that the 3 arms looks identical. So if you have a very low risk patient, you might not need to escalate the treatment from tamoxifen to ovarian function suppression plus aromatase inhibitor. However, in those patients who were typically larger tumors, node positive, and younger patients, those with high risk patients that were considered high risk enough to go for chemotherapy, then the benefit here looks like it's up to 7%. So you have 86% with tamoxifen with ovarian function suppression plus exemestane. You have around 82% for those with tamoxifen, and for those with only 5 years of adjuvant tamoxifen, the 5-year disease-free survival is only 78%. So what about very young patients, patients who are less than 35 years old? you can see that you might not see enough difference between the ovarian function suppression plus either tamoxifen or exemestane. However, please look at that. The arm with tamoxifen alone do perform very poorly in those patients. So if you have a lady who is 30 years old and she's refusing, for example, ovarian function suppression plus exemestane for the musculoskeletal side effects, for example, you can still offer ovarian function suppression plus tamoxifen, and please advise her against having tamoxifen alone. You have very high risk with that. She has 1 in every 3 patients would relapse if you give only tamoxifen. More and more benefits shown with the long-term outcome. At 8 years, you can see that the curves are separating progressively in all patients to have around 7% between tamoxifen and exemestane. In addition, in those high risk, you have 9% absolute gain. So it's around 1 in every 10 patients are saved in those high risk patients if you give ovarian function suppression plus exemestane. Now we have a 12-year report for follow-up for the soft and text studies. And as expected, you have persistent benefit in the whole cohort, even not in the high risk alone, by around 5% long-term outcome. So the long-term outcome is there to not only delay the relapse, but you can prevent the cancer recurrence. And we are starting to see some sort of overall survival improvement with that long-term outcome. You have around a trend of a 2% improvement. Again, we expect that to get more and more, get bigger, the benefits with time. Again, if you are giving your patients this more effective ovarian function suppression plus exemestane, you must look into the side effects, because surprisingly, this is not a very benign indication. Ovarian function suppression plus exemestane or plus even tamoxifen causes 50% risk of depression. That's real clinical depression, not like I feel a bit sad sometimes. In addition, around 4 to 5% of them have grade 3 to 4 depression. And if you're wondering what's that, that's when you are inside a psychiatric hospital because you're trying to kill yourself. Again, with that medication, keep an eye on the psychological toxicity of this medication. In addition, you have really relevant sexual dysfunction with ovarian function suppression, even if you're using tamoxifen, not AI. In addition, you have a significant risk of urinary incontinence. Again, grade 1 to 2 urinary incontinence, but I don't see anybody want to have want to know what is grade 1 urinary incontinence. Again, that is some serious medication. And please note that those patients are young patients, so they are functioning, they have to take care of the family and all that. So to the other step around, what about the low risk patients? Do we have some patients where we can de-escalate, can give this treatment and still keep saving them from having cancer recurrence? What to do? First, we can omit chemotherapy. If you ask any patient, what is the de-escalation? What's the less treatment that you want to avoid? They will tell you 99% of them, I don't want chemotherapy. You can give me any duration, any type of endocrine therapy, any type of target therapy, they would accept that. So less treatment in the minds of every single patient means less chemotherapy. Could you avoid chemotherapy for low-risk patients? We will see. In addition, what we've mentioned before, some patients might be indicated only for tamoxifen. And my advice is to evaluate the risk and benefit ratio for every single young patient with endocrine responsive early breast cancer, because some patients would not tolerate the toxicity of ovarian function suppression and might even stop taking their medication. Do you know how many of the soft and text studies completed the 5 years of the adjuvant endocrine therapy, the ovarian function suppression plus tamoxifen or plus aromatase inhibitor? Can you guess? There are 80%. 20% of the soft and text patients did stop medications, stop their assigned ARB because they were not tolerant to toxicity. So please discuss with your patient the expected side effects, and if you will not tolerate them, you can de-escalate automatically to tamoxifen. But let's look into this point that most patients would really be happy to omit. Now we have genomic tests that can help us with de-escalation. Gene expression profiling simply means that you do study the product of the gene. That's the messenger RNA. The product of the gene is either expressed, so you do produce RNA, or not expressed, where you do not produce RNA. And these, the expression versus no expression, are coded by the green and the red dots in this diagram. And you can group each cohort of patients that have similar gene expression profile. So every group of patients have similar group of genes that are expressed and similar group of genes that are not expressed. And hence, we got the biological subtypes, luminal A, luminal B, basal, and auto. And we can see that those subtypes have its implication on the prognosis. The oncotype DX is a gene expression profiling gene that uses only 21 genes, typically 16 that are important, and to get a recurrence score. So you don't see the green and red dots, but you see a score from 0 to 100 that's called the recurrence score. And if you did to 100 patients, the gene expression profiling, the oncotype DX, around 1/3 of them would have the low risk cohort, and you have only 7% risk of recurrence. At 10 years, if you're having low risk, you're having 14% risk of recurrence, intermediate risk, and you're having 30% of high risk. And again, that's the 18 to 20 cutoff, the old cutoff. And that's the difference between chemotherapy versus no chemotherapy according to the rest. On the left-hand side, the low risk, in the middle, the intermediate risk, there is no benefit, no additional benefit of adding chemotherapy to those patients. However, on the right-hand side, the high-risk population, you can see significant gain from adding adjuvant chemotherapy. This is a sample report of one of my patients. She got a recurrence score of 24. What does this mean? It means around 19% risk of distant recurrence. That looks high, but again, that's intermediate. And this is the recurrence probability with tamoxifen alone, the dotted, the solid black curve, and tamoxifen plus chemotherapy in the dotted curve. And my patient's lies in the 24 recurrence score, means that if she received tamoxifen alone, she might not have adequate separation of the curves. So you can omit in those patients, some of those patients, you can omit chemotherapy. Do we have a prospective value for that? Yes, the Taylor X study did randomize patients to assigned patients with high risk, chemotherapy, low risk, no chemotherapy, and intermediate risk, and by here we mean 11 to 25, into chemotherapy versus no chemotherapy. And this is the results. Simply, you can see that the only poor prognosis patients are those with high risk patients, even if they receive chemotherapy. But the low risk and intermediate risk patients, whether or not they receive chemotherapy, they have good prognosis. Again, this is the predictive value, chemotherapy versus no chemotherapy, because you cannot even differentiate the lines. However, the benefit is different according to the age. Low risk is low risk, high risk is high risk, but in women less than 35, in women less than 50 years, you have around 1.6% chemotherapy benefits. They have 16 to 20, and around 6.5, they have 21 to 25 recurrence score, which means that some of them might opt for chemotherapy. The responder study is same study, but in node positive and one district, chemotherapy versus no chemotherapy. And for all population, you have a minute difference of 1.4%. However, if you look by the premenopausal patients, those on the right-hand side, you can see that the difference is 5%. So if you have positive patients who is 11 to 25, please allow her to receive chemotherapy, because it saves around 5 of every 100. It doesn't matter about the risk of recurrence score, because the recurrence score, even as low as 0 to 15, might have some significant benefit, yet smaller benefit from the addition of chemotherapy. So if she has a recurrence score of, for example, 5, I might opt to omit chemotherapy for a young patient with even non-positive disease. Overall survival, we still do not have statistically significant results, but there looks like a trend in the premenopausal patients with node positive to receive chemotherapy. Finally, do we have other tests? We have one of them, the MammaPrint, that's also prospectively validated in the MIND-ACT study, showing very similar results that low genomic risk patient can avoid chemotherapy and have a prognosis that is equal to anatomically low risk patients. Finally, personalizing the treatment in our minds usually is linked to doing some genetic testing and doing assigning each patient for a target therapy according to the genes. However, real personalization of treatment is involved with personalizing the treatment strategy to the patient's social factors, to her financial status, to her expectation of treatment, and finally, to her tolerance to medications. Thank you very much.
Thank you very much, Professor Loai, for this elegant presentation and tackling this very important issue.
Now to move to Professor Shayma Lashin. She is Assistant Professor of Clinical Oncology, Qasr Aini. She will present landscape of target therapy in early breast cancer. Please, Prof.
Thank you very much for the lovely introduction. Thank you very much. Okay, thank you very much for the amazing Baheya team for having me again in this very nice conference. Thank you, Dr. Amani, for extending your lovely invitation to me again. It's always a pleasure. And of course, I'm in awe standing in the presence of this very nice chair persons and my dear colleagues. So actually, I was given a topic covering the landscape for target therapy in early breast cancer. And to be quite honest, if this topic was given to me 3 years ago, this would have been a very easy, straightforward topic of covering basically HER2-positive breast cancer. But given this topic today, actually, it was very challenging for me to think of what to discuss with you today. It was really difficult. And the nice thing is many of my colleagues will cover many topics related. So I thought of, okay, let's just try to position the different target therapies that have gained approvals or have been practice changing in early breast cancer. And let's just take a glimpse into the future of what the future holds for more and more target therapy in early stage breast cancer. So, of course, as you all know, breast cancer is the second most common killer of among females when it comes to malignancy. Thank God, in the last 2 decades, we have been having monogamous improvement and progress in targeted therapies. And of course, as you all know, once we have a very good improvement and success story in the advanced setting, we have a shift up towards the early setting to see what addition we can make. It's more difficult to do improvements in the early setting, but when you hear an improvement in disease-free survival or overall survival, we always perk up our ears because we know we have a better chance of winning the battle in the early stage than doing so in the advanced stage. That's where you should pick how to position your treatments. Of course, this has been helped by the advances in understanding breast cancer biology and the improvements we have seen with therapeutic targets in the advanced stage has, thank God, been also translated in the early stage of breast cancer. So I will try to go through the different subtypes of breast cancer, and my main focus would be on the hormone receptor positive HER2 negative, because I think this is where we have had many practice-changing data in the last couple of years. And this is also to complete upon the thoughts that Dr. Lai has been discussing in the previous session. Okay, in the essence of things, we have to identify that the oldest and the most understood target in breast cancer has always been targeting the estrogen receptor. And tamoxifen, at the end of the day, is nothing but a target therapy that is targeting the estrogen receptors through selective modulation. So this chart just shows you in early breast cancer, of course, we mainly look at Okay, in early breast cancer, we mainly look at aromatase inhibitors and targeting the estrogen receptor through either tamoxifen or down regulators like fulvestrant or oral SERDs, which are not yet in practice in early breast cancer. And then we have had a vast improvement with in metastatic breast cancer with the CDK4/6 inhibitors and targeting the mTOR PI3K AKT mTOR pathway. Okay. The first to deliver in early stage breast cancer, understandably, has been the CDK4/6 inhibitors with the very impactful improvement they showed in first line and second line treatment in advanced hormone receptor positive HER2 disease. They shifted up to in the adjunct to early stage hormone receptor positive HER2 disease. And these are the phase 3 trials that we have data for CDK4/6 inhibitors in early stage disease. We have them in the adjuvant setting. We have 2 trials with palbociclib, the Penelope B and the Palace trials. The Penelope is the smaller trial. Somewhat, both trials, one of them, the Penelope, was using palbociclib for only 1 year, while the Palace used palbociclib for 2 years. And both trials, despite a bit of a numerical improvement in invasive disease-free survival, which is across the board the primary endpoint in all trials, unfortunately, it did not show any improvement. So it looked like palbociclib was still struggling in its endpoints for disease-free and overall survival in metastatic setting. Now let's look at the 2 more recent trials, data that we have that are positive, which are the Monarch-E and the Natalie, and I will discuss these 2 trials in more details. The first one to deliver was the Monarch-E, and we have had the results from the Monarch-E for a couple of years now, where patients with high risk node-positive hormone receptor positive breast cancer, and please look at the cohorts, most of the patients are patients who had N2 disease or N1 disease with grade 3 or tumor that was T3 or more. And then they allowed a small cohort of patients who had, because this was closed later on, who had 1 to 3 lymph nodes and a high Ki-67 or percentage testing or grade 1 to tumor size less than 5. So basically 1 to 3 lymph nodes. And the randomization was for abemaciclib, 150 milligrams BID, the usual dose, and it was given for 2 years compared to the endocrine treatment of choice. So the comparator could be tamoxifen, aromatase inhibitor, ovarian function suppression, premenopausals, or whatever. And these data we have had for a couple of years. The study was positive. There was a 5% improvement in invasive disease-free survival, and this was a significant improvement. So a relative reduction of about 25% of the risk of invasive disease relapse. For distant recurrence-free survival, it was 28.3% reduction after 3 years. And this is the last update where they showed us the data for, and I will go very rapid here. They will show us the data according to age, because we're always skeptical about using abemaciclib in elderly patients. So they gave us the data for patients above 65, and I will just show you this slide, which shows you that in the intent to treat population, we had an absolute improvement of invasive disease-free survival of 6.4%. And if you look according to age, there was a benefit in both groups, but of course it was more pronounced in the younger patients below 65. Same goes for distant recurrence-free survival and for toxicity. Understandably, it wasn't, but still they gained more or less the same benefits. So the signal is, even if a patient is above 65, there is benefit of administering or prescribing abemaciclib in the adjuvant setting. This is the latest edition. We had the Natalie, the last ASCO, where the Natalie was randomizing patients. More or less, they added more intermediate risk patients, not only high risk patients, because this study involved patients with stage 2A disease. If the patients were node negative and they had either grade 3 or grade 2 and a high Ki-67, and for the first time, they included patients with a high genomic risk profile. So if you are segregating your patient based solely on your genomic profiling or oncotype DX, Natalie was the one that used this for randomization. And here randomization was for ribociclib, and they went down with the dose of ribociclib to 400 rather than 600. And it was for up to 3 years, while abemaciclib was for 2 years. And the comparator was non-steroidal anti-aromatase inhibitors only, Hetero or Arimidex. As you can see, both groups were homogeneous. Most of the patients were stage 3 disease. 60% were stage 3, 40% were N1 disease. In abemaciclib, you have more advanced patients. More, as I showed you, 60% had node negative disease, and most of those were actually 4 axillary lymph nodes or more. Okay, and these are the results that were presented in the last ASCO. As you can see, at 3 years, this was the interim analysis proved an improvement of invasive disease-free survival of 3.3%. It was 90.4 when we added ribo versus 87.1 at a hazard ratio of 0.70, so 748. And for distant disease-free survival, and for distant disease-free survival, we had an improvement of 2.2%, significant as well. Overall survival, of course, it's too early in hormone receptor-positive breast cancer to look at early breast cancer in general, to look at overall survival. There is improvement, understandably, it did not show significance. Regarding toxicity, we have the understandable toxicity, but I want to show, to mention that we have 20%, and this is across most studies with the PARP inhibitors, with the CDK4/6 inhibitors in the adjuvant setting. The discontinuation rate is usually between 20 and 25%. With palbociclib, it was even higher. But because they went down with the dose of ribociclib to 400 milligrams, they had an improvement in neutropenia and of QT interval prolongation. So this is we have, and inevitably we will have probably an FDA approval for ribociclib for this indication. So we have now the first and most striking is the addition of CDK4/6 inhibitors in the adjuvant setting. We also have the addition of PARP inhibitors in the early cancer. I mentioned this here in hormone receptor positive because most of the triple negative was covered by Corona. And we have the Olympia trial. The Olympia trial, we have had data for also for about 3 years. And in this trial, patients who have germline BRCA mutation, either they have triple negative breast cancer that is a non-PCR after neoadjuvant treatment, or it is node positive or T2 or more if the patient did not undergo neoadjuvant treatment. For hormone receptor positive, our patients, those are the patients who have N2 for axillary lymph nodes or more, or patients who had received neoadjuvant chemotherapy and did not achieve a pathological CR. And not only that, they use what is called the CPS-EG score, which is a computerized score developed by MD Anderson to look at the pathological response in those patients. The randomization was olaparib for 1 year versus placebo. And the primary endpoint is also invasive disease-free survival. I will go very fast. Where invasive disease-free survival from the first on record, you can see a very nice separation starting on from the very beginning of the curve at 36 months. At 3 years, we have an absolute difference of 8.8% between those patients who received olaparib or not. And this was a hazard ratio of 0.58 and a significant p-value. And if we look at the subgroups, we will find that almost most of the patients or all of the subgroups benefited from the olaparib, except maybe those patients who had received previous platinum, but these were very small numbers of patients because understandably, not all patients received platinum, especially in those patients who are hormone receptor positive. For distant disease-free survival, also we had an improvement of 7.1% at 3 years, a significant improvement. For overall survival at that record, it was not yet, it was a 92 versus 8.8%, but it did not hit the boundary for significance. But in the later record last year, we had the final improvement at 4 years. We have a 3.4% in overall survival. So this is the first target therapy to produce an improvement in overall survival in early breast cancer, early hormone receptor positive breast cancer. And these are the safety issues. What does the future hold? Very rapidly, I will just remind you that we have to look out for 2 things in hormone receptor positive. First of all, CDK4/6 inhibitors are being developed wide and around in the neoadjuvant setting. Unfortunately, up till now, because most of these trials are window opportunity trials, it has not delivered. The endpoint is usually looking at the Ki-67 reduction after a CDK4/6 inhibitor. It usually does produce a significant reduction of Ki-67 when compared to endocrine treatment alone. However, it looks like this is a reversible reduction because in the trials where over time Ki-67 was followed after you stopped the CDK4/6 inhibitor, you did not have that permanent reduction of Ki-67. Now we have trials ongoing that are more clinically meaningful, comparing this combination to chemotherapy, because at the end of the day, this is still the standard of care for hormone receptor positive breast cancer. Also for the oral SERDs, and ever since the approval of the elacestrant we had at the beginning of this year in second-line metastatic breast cancer, we should be looking out for trying to position oral SERDs, and we will start hearing after a few years about oral SERDs in adjuvant setting and in the neoadjuvant setting for early breast cancer. Finally, we have had this break news a few days before. It was first in July 2023, where in the keynote 756 pembrolizumab was used in hormone receptor positive HER2 negative breast cancer in a design very much similar to that of the keynote 522. And the announcement was that it had hit its primary endpoint of PCR. However, the co-primary endpoint of event-free survival is not yet out. It is interesting for us to read the rest of the publication, but yet this is not to change practice maybe in the next couple of years. Okay, HER2 positive, this is a huge landscape for target therapy. It is a very well-rooted landscape. So I will not really actually go into the details. These are just the trials that remind us why trastuzumab is well-rooted for improvement of disease-free and overall survival. And then we had the addition of pertuzumab, very well understood in the neoadjuvant setting. We have the Neosphere and the Trifina trials, and also in the adjuvant setting with the Affinity trial, maybe at least in the node positive. So I think all of us now that more or less a dual anti-HER2 blockade is standard of care, preferably used in the neoadjuvant setting. Maybe after neoadjuvant continue or not, that is one of the questions. So more or less, this is an algorithm to remind ourselves how we treat our patients with HER2 positive breast cancer. And this is just to remind ourselves of the questions and the gaps of knowledge that we have. In patients who have advanced disease, it's at least 2 centimeters or above. I think we all know that the standard of care is going for chemotherapy with dual HER2 blockade. Most of us use the TCHP anthracycline-free regimen. If the patient does not achieve a PCR, we go to the TDM1. And we have data for neratinib with the Xtinet. However, we're not quite sure of positioning neratinib after TDM1. We know of positioning neratinib after trastuzumab, but not after TDM1. This is one question. For the PCR patients, most of the guidelines will tell you to go ahead and continue with dual anti-HER2 blockade, but we are not quite sure, because if we have achieved the PCR, it bears to make sense that we should use this endpoint to somewhat de-escalate adjuvant treatment for the patient. So that's another question, whether or not to resume a dual blockade after a PCR. And then in the early setting, there are a lot of questions that are related to de-escalation, especially if the patient has hormone receptor positive breast cancer as well. I will show you only one trial because I really think this is a mind-opening trial. And this should be the future of being more dynamic with our neoadjuvant treatments. This is the FERGAIN trial, and this is a phase 2 trial that was presented in the last ASCO. And it's a very nice trial where patients were given the option to receive dual anti-HER2 blockade chemotherapy-free regimen. So the patient received only trastuzumab, pertuzumab, and no chemotherapy. Of course, the comparator arm was TCHP, the standard, and the patients then, based on assessment of response by PET-CT, the standard arm will continue with TCHP, do the standard, basically what we do now, and then after surgery, resume pertuzumab, trastuzumab. Group B patients, these were the patients where we were trying to de-escalate and be more dynamic, being chemotherapy-free, and then randomizing the patients. If the patient is responding with at least 40% improvement in PET scan after 2 cycles, the patient resumes her treatment without chemotherapy. If the patient is not responding, we shift her back to TCHP, and then the rest of the data is for the patient's chemotherapy-free after surgery. Primary endpoint is in those patients who are PET responders, what percentage of PCR did we have, and how many patients could we spare chemotherapy? And that's the endpoint that really matters. What is the percentage of patients that could be spared chemotherapy? Most of the patients were stage 2 disease, and most of them were hormone receptor positive. And the patients who received without any chemotherapy had a rate of 37%. So out of every 3 patients, 1 patient achieved PCR without receiving any cycle of chemotherapy. And to me, this is really, really striking. And for a more important disease-free survival, invasive disease-free survival endpoint at 3 years, it was 95.4%, a number that is very difficult to improve above in patients. Most of them were not positive disease to start with. And this is a comparison of all groups, including patients who did not receive chemotherapy. At the end of the day, 86 patients of the 350 that we started off with received a full treatment without any chemotherapy, only trastuzumab and pertuzumab. I will not go further with HER2. And in triple negative breast cancer, thank you, Dr. Ola. She has covered most of the topic. This is just a reminder, and Dr. Ola has gone through even more of the data on immune checkpoint inhibitors, and this is where we are now. It's not the future. Keynote 522 is now the standard of care for triple negative breast cancer, starting off with in any node positive or T2 disease in combination with full chemotherapy. And as you know, improvement of PCR and event-free survival regardless of PD-L1 status. The questions that were raised also by Dr. Ola, should we continue really pembrolizumab in the adjuvant setting? We have an ongoing trial, thank God. Also, for those unfortunate patients, our patients, for example, where we could not give in the neoadjuvant setting, those who did not achieve a PCR, because if the patient has achieved PCR, we already have learned it's no big deal. We don't have to go for the immune checkpoint inhibitor. But for those who did not achieve a PCR, there is an ongoing swap trial that is looking at randomization to pembro versus observation. And these are the trials that were mentioned by Dr. Ola. Finally, and this is my final slide, please await for the upcoming trials with the ADCs. The ADCs are coming fast. It's a flood of ADCs in every aspect of breast cancer. Triple negative is, of course, the prototype. I think we will hear about secretosumab govitecan and TDXD in early breast cancer, and especially the SG quite soon, especially in triple negative breast cancer. I'm very sorry to take so much time. I'm not sure if I crossed the time. Thank you very much. I hope it was informative. Thank you.
Thanks, Prof. Shaima. Very informative, but clear. Thanks a lot.
Now we move the fourth speaker, our dear Professor Dr. Amira Daya. Amira is the Professor of Medical Oncology, NCI, and consultant of Baheya Breast Cancer Hospital. Please, Dr. Amira.
Thank you, Chairman. Thank you, my colleague. Thank you, Dr. Amani. I know it's late, and we have many lectures, but I will try to briefly discuss my presentation. My presentation on role of extended adjuvant endocrine treatment, benefits and risks. Adjuvant endocrine treatment, about 70% of breast cancer are endocrine receptor positive, and the cornerstone of treatment is endocrine therapy. That could either be tamoxifen or an aromatase inhibitor or ovarian function suppression in premenopausal women with one of those classes of aging. Adjuvant endocrine treatment reduces breast cancer recurrence and improves overall survival in estrogen receptor positive patients. The optimal duration of adjuvant endocrine treatment has long been debated. For decades, 5 years was the standard recommendation. However, women with estrogen receptor positive breast cancer remain at jeopardy for recurrence. And it's about more than 50% of women with hormone receptor positive luminal breast cancer will recur after 5 years of adjuvant endocrine treatment. Then I'm going to discuss what the rationale behind the extended endocrine therapy. Recently published a meta-analysis that included 88 trials in the early breast cancer trials group that involved more than 63,000 women with estrogen receptor breast cancer patients who were disease-free after 5 years of scheduled endocrine therapy to assess the association of tumor grade and other factor outcome during the period from 5 to 20 years. And it was found that after 5 years of adjuvant endocrine therapy, breast cancer recurrence continued to occur steadily throughout the study from 5 to 20 years. And the risk of distant recurrence was strongly correlated with original lymph node status, tumor size, and grade, with risk ranging from 10 to 41%. And here a figure showing that according to the lymph node status, that there is a continuous increase in the annual risk of recurrence all through from 0 to 20 years. However, 2/3 of the patients included in this meta-analysis had received only tamoxifen as adjuvant endocrine therapy. Moreover, HER2 receptor status was also unknown in 50% of patients, and 40% of patients were diagnosed before the year 2000, with only 13% of the patients being diagnosed after 2005, meaning that many patients in this meta-analysis were treated suboptimally. Hence, we cannot conclude from this trial that we should extend hormonal treatment. Then,
What is the safety and the efficacy of endocrine treatment? The three recommended extended endocrine treatment are either extended administration of tamoxifen after 5 years of adjuvant tamoxifen, extended administration of aromatase after 5 years of adjuvant tamoxifen, and extended administration of aromatase inhibitor after adjuvant endocrine therapy. In the upcoming slides, I will discuss each one. The efficacy and safety of extended tamoxifen was presented in the ATOM and the ATLAS trial, where a follow-up after 9 and 8 years, there was an absolute benefit in disease-free survival in favor of extending adjuvant hormonal treatment tamoxifen for 10 years. However, the prolongation of tamoxifen slightly increased the incidence of endometrial cancer as well as increased thromboembolic risk. Then, based on the result of text and SOLT trial, ovarian function suppression and aromatase inhibitor for 5 years have been proposed as adjuvant endocrine treatment for hormone receptor positive premenopausal patients at high risk of recurrence. And hence, in the recent 2023 St. Gallen conference, they were discussing whether premenopausal patients with stage 3 breast cancer after 5 years of ovarian function suppression agonist plus non-steroidal aromatase inhibitor, should they extend endocrine treatment or not, and only 8% of the experts discontinue therapy, and 35% of the panelists recommend continuing with tamoxifen. Second, the efficacy and safety of extended therapy with aromatase inhibitor after tamoxifen. The MA17, the DATA trial, and the GIM4 trial addresses the efficacy of extended therapy with aromatase inhibitor after tamoxifen. In the MA17 trial, after a median follow-up that included around 5,200 patients, they are randomized between after 5 years of completing their adjuvant treatment, whether to continue letrozole for 5 years or to receive placebo. And after a median follow-up, there was an absolute benefit in favor of extending treatment with letrozole. The DATA trial, the first analysis published on 2017, they explained that around 2,000 women were enrolled in the study after 2 to 3 years adjuvant tamoxifen, and they are randomized between anastrozole 3 years versus anastrozole 6 years. And after a median follow-up of 8 years, it was found that there is a disease-free survival absolute benefit of 3%, which wasn't statistically significant. However, after stratification of the patient according to hormone receptor positive and node positive, the difference was statistically significant. Also, the updated results of the DATA trial published 2022, they found that there is, after a median follow-up of 10 years, there is a continuous improvement in disease-free survival, favoring the anastrozole extended treatment. The GIM4 trial randomized patients to receive letrozole 3 years versus 5 years after adjuvant 2 to 3 years. And then after a median follow-up, there was a significant gain of benefit in the disease-free survival and overall survival. Lastly, the efficacy and safety of extended therapy with aromatase inhibitor. The 3 trials, the IDEAL trial, the NSAB, and the CSG trial, they are randomizing postmenopausal patients who are receiving tamoxifen, anastrozole, or tamoxifen switching to anastrozole, either to letrozole for 2 years or extended therapy with letrozole 5 years. And after a follow-up of around 7 years, there was an absolute benefit in disease-free survival of 3.2% and in overall survival. The NSAB E42 trials found that there is, after a follow-up of 9 years, there is also an absolute benefit of 4%, both in the disease-free survival and significant overall survival benefit for patients receiving letrozole versus those who received placebo. Finally, the ABCSG trial published 2021, they are randomizing postmenopausal patients either to receive anastrozole for 2 years or anastrozole for 5 years after tamoxifen or anastrozole, or switching tamoxifen anastrozole 5 years. And again, there was a benefit in disease-free survival, and however, there was no benefit in overall survival. Gray et al. Published a meta-analysis on concerning the patient of the trial of early breast cancer trial group and 25,000 women presented in the San Antonio breast cancer, and they found that the extended therapy beyond 5 years resulted in overall 35% reduction in risk of relapse for patients treated with an aromatase inhibitor following tamoxifen alone, but suggest there is a more moderate reduction after prior aromatase inhibitor therapy. And Chen et al. Discussed the results of nine randomized controlled trial, including 22,000 postmenopausal patients, to discuss the optimal duration of endocrine treatment with extended aromatase inhibitor, and they found that prolonged endocrine treatment beyond 5 years improved disease-free survival in patients with estrogen receptor positive tumor and primary tumor size more than 2 centimeters, and previous endocrine treatment with tamoxifen or tamoxifen followed by aromatase inhibitor. However, there was no substantial difference observed between a total endocrine treatment of 7 to 8 years versus 10 years. Then what about the risk of extended adjuvant? There was muscle and joint pain, cognitive impairment, as well as loss of libido and sexual health. This can be a major burden on the individual patient daily life, and thus can compromise the adherence to therapy, and can lead that some patients may stop taking their adjuvant treatment. Also, there is increased incidence of endometrial cancer as well as increasing thromboembolic risk. This review of meta-analysis discussed the toxicity of extended adjuvant therapy with aromatase inhibitor in early breast cancer. It comprised 7 randomized controlled trials, including around 16,000 patients, comparing extended adjuvant aromatase inhibitor to placebo or no treatment using the Medline database and review of abstracts from key conference between 2013 and 2016. And they found that extended treatment with aromatase inhibitor is associated with increased risk of cardiovascular event and bone fracture, and there is no statistically significant increase in death without breast cancer recurrence among patients receiving longer treatment. Here the pooled absolute risk of adverse event in the 7 trial, and positive results here shown in the table show that there is excess event with prolonged aromatase inhibitor. Here in the cardiovascular disease, all the extended adjuvant treatment are associated with increased risk versus the non-extended. Also, those patients who need to treatment discontinuation and patients who have second cancer, was no difference with extended adjuvant treatment. Then, how to stratify patients and how to select patients who are going to be receiving extended. Many factors can be used, clinical pathological factor and some genomic assay. As for the clinical pathological factor, considering the variable clinical benefit driving from extended endocrine treatment and the increased toxicity, optimal patient selection is crucial. And here, Garuti et al. In 2022 examined the various clinical pathological factors to identify the clinical risk factor in early breast cancer. And they concluded that high histological grade, high histological grade and positive disease, tumor size T2 or greater, high level of Ki-67 expression, low ER expression, residual cancer burden after neoadjuvant treatment, and high risk class genomic signature. All these are risk factors and promote extended adjuvant treatment. Another factor is the clinical treatment score at 5 years. And here we are in the era of the artificial intelligence and the medical calculator. It's an equation using some factors in order to determine a score, whether to add extended treatment or not. This is a clinical score that estimates the risk of late recurrence after standard 5 years. The score was developed by Doxit et al. Based on data from the ATTACK trial and validated in the Big 198 trial of adjuvant letrozole and or tamoxifen alone or subsequently. The clinical treatment score was validated in three trials, where Tajiri et al. Investigated the clinical usefulness of this score in a study of 560 postmenopausal patients and concluded that patients with CTS5 intermediate and high risk of recurrence might be a good candidate for extended endocrine treatment. Richmond, they conducted another retrospective study on 2,000 and around 500 patients with estrogen receptor positive early breast cancer, and women with a low CTS5 risk are unlikely to benefit from the extension of endocrine treatment beyond 5 years. Conversely, women with high risk might prolong. The TERX trial also, the CTS5 score was strongly prognostic for late distant recurrence in patients older than 50 years, while it was less prognostic for women aged 50 years or young. Number of genomic biomarkers can be used also for risk stratification. Number of assays provide valuable prognostic information with hormone receptor positive HER2 negative early breast and are also used to identify candidates for adjuvant chemotherapy, namely the Prosigna, the Oncotype DX, the EndoPredict, the breast cancer index, and the mammogram. The Oncotype DX in the TransAttack study evaluated the prognostic value of the Oncotype DX recurrent score beyond the 5 years of endocrine treatment. However, it was impossible to determine the optimal duration of adjuvant endocrine treatment based on the recurrent score. Only the EndoPredict, the Prosigna, and the breast cancer index are able to provide reliable prognostic information beyond 5 years from primary diagnosis. Two prospective trials have been performed to specifically demonstrate the capability of all these assays to efficiently discriminate patients to benefit or not from the extended adjuvant endocrine treatment. Furthermore, the breast cancer index can predict tamoxifen benefit, and the Prosigna can identify the molecular breast cancer subtype that might be helpful beyond the clinical pathological evidence to identify tumor with higher or low endocrine sensitivity. Here in the ITL trial, the utility of 70 gene mammogram tests for prediction of extended endocrine therapy benefit are designed, and they found that they divided patients into high risk, low risk, and ultra low risk, and there was an absolute benefit in those of the low risk group that could benefit from the extended adjuvant treatment in all endpoints concerning the absolute benefit of recurrence and overall survival. And then what about the duration of extended endocrine therapy? The duration of the study in this study by and he found that extended adjuvant endocrine treatment in 2 years versus 5 years was similar, and there was no difference neither in disease-free survival nor in the overall survival. But what about making another schedule? How can we use intermittent versus continuous extended therapy? This issue was addressed in the SOUL study. They found that among women who had received 4 to 6 years of adjuvant endocrine therapy, the SOUL trial compared additional 5 years of continuous letrozole versus an intermittent schedule, in which anastrozole was given for 9 months, followed by a 3-month break each year. And they found that there was no difference in disease-free survival between the two schedules, with better tolerance of intermittent schedule supporting potential safety of temporary treatment breaks in patients who might require such interruption. Finally, I'm going to discuss and summarize the guidelines. The updated ASCO clinical practice guidelines that was published since 2019 hasn't been changed up till now, and they found that patients with not positive breast cancer should receive extended adjuvant endocrine treatment for up to a total of 10 years. Either tamoxifen for 10 years, tamoxifen for 5 years, followed by aromatase inhibitor for 5 years, tamoxifen for 2 to 3 years, followed by aromatase inhibitor for 7 to 8 years, or aromatase inhibitor for up to 10 years. The NCCN guidelines, they found that one of the following extended adjuvant endocrine treatment for patients can be used: either tamoxifen for 2 to 3 years, followed by 5 years of aromatase inhibitor, tamoxifen for 4 to 6 years, followed by 5 years of aromatase inhibitor, or tamoxifen for up to total of 10 years. Lastly, the St. Gallen, they found that in stage 1 disease, 88% of the panelists supported 5 years duration of extended treatment. And in stage 2 node negative disease, 45% favored 5 years, and 37% of the panelists favored 7 to 8 years. In stage 2 node positive disease, 68% of the panelists recommended 7 to 8 years of extended treatment, while in stage 3 disease, 69% of the panelists favored 10 years duration. 61% stated that they wouldn't use a genomic assay to determine endocrine treatment duration. Finally, my take-home message that the concept of extended endocrine treatment is a double-edged sword. In a way, aims to improve disease-free survival, overall survival, on the expenses of toxicity. Decisions related to extended endocrine treatment are challenging and complex between patient and clinician in daily clinical practice. More evidence is needed to support the efficacy, safety, quality of life, and cost-effectiveness in patients with hormone receptor positive early disease. Patients with low risk and an additional 2 years of treatment is appropriate, and the benefit of a total of 10 versus 7 years are small, if any, in women with low risk cancer. For patients with high risk disease, a total duration between 7 and 10 years is appropriate, with preference for the higher end of this range if treatment is well tolerated. Suggested algorithm here, we can define the patient into low risk, medium, and high risk according to the stage and the TNM classification and risk of relapse, either to use 5 years, 7 years, or 10 years. Lastly, knowing that adjuvant treatment in luminal are rapidly evolving, a cyclin-dependent kinase inhibitor and PARP inhibitors are now indicated after result monarchy and Olympia trial Natalie trial. Further studies are needed to better understand the role of extended endocrine treatment in patients receiving those double agents. Thank you.
Thank you, Dr. Professor Amira. Second speaker.
I have the pleasure to introduce Professor Ahmed Magdi, Deputy Director of Medical Oncology, Baheya Cancer Center, and Assistant Professor of Medical Oncology and Hematology, National Cancer Institute, who will talk about immunotherapy in breast cancer between present and future.
Thank you so much for the beautiful introduction. So I'm going to go quickly. So I've been talking a little bit, giving hints about specific introduction, PARP inhibitors, checkpoint inhibitors, ADCs, and what do we have for the future. We all know this, so I won't go in details about that, but we have to know that breast cancer in transit subtypes, that the ER positivity is only 75%, while HER2 20 and triple negative 15%. And always remember, as we mentioned in the previous lecture, triple negative now is a heterogeneous disease. So if we looked at what we have now, we do have the immunotherapy. Of course, the antibody drug conjugates, the sacituzumab govitecan, already the anti-TROP2, and we have another player, the datopotamab, which is another coming anti-TROP2. We do have the PARP inhibitors and we have the AKT inhibitors. But why did we look at the immunotherapy? Why did we check for immune checkpoint inhibitors in breast cancer? Because it was found out that tumor mutational burden is variable among subgroups of breast cancer. And I would like to ask you to read this paper because this paper is really nice. It was published this year, looking at what is going on with the trial of immunotherapy in breast cancer. So if you look at the A curve, you'll find that the immune checkpoint inhibitors started at the 2000s, and while reaching 2015, you can see the boost up in the immune checkpoint inhibitors. And then don't ever forget that we do have ongoing vaccine or anti-vaccines for breast cancer, which is actually gaining ground. Yet we have no strong evidence for that. And then if you look at the immune checkpoint inhibitors as metastatic, again, you see the curve B, you'll find it markedly rising. And then it starts to rise in the neoadjuvant. And now we do have the Keynote 522 trial. And then again, if you look again and again, you will find that we are improving our immunotherapeutic approach to breast cancer. What about the PARP inhibitors? We all know that the PARP inhibitors or PARP is working on the single strand break. So we prevent the single strand break, the fixation of the single strand break, then we will lead to accumulation and death of the cell. And this is the mechanism behind using the PARP inhibitors in the Olympian trial with adjuvant olaparib in BRCA1, BRCA2 mutation. As you can see, the delta gain at 3 years is 8.8% in invasive disease-free survival and distant disease-free survival of 7.1%. However, in the overall survival, you still get a delta improvement of 3.7% at 3 years. This is the subgroup analysis showing the Olympia trial and the gain for those patients. And if we looked at the NCCN guidelines, the most recent, you'll find that the olaparib, if germline mutation, is recommended in the adjuvant setting. What about the Olympia D or the Olympiad trial, which is a phase 3 in germline mutated metastatic breast cancer? And again, we do see that we do have a good progression-free survival with a very impressive hazard ratio of 0.58, and we don't have yet an improvement in overall survival. However, if you look at the subgroup analysis, if you look at the curve B, you'll find that there is a trend towards improved overall survival if you did not use chemotherapy prior to using the olaparib. However, in general, no effect in generally the intention to treat population on overall survival. And if you look at the NCCN guidelines, you'll find that germline mutation with PARP inhibitors again in second line. So yes, there is a numerical difference for overall survival, yet the approval is second line. What about the immune checkpoint inhibitors? We do get an improvement with a good durable response using the immune checkpoint inhibitors. And as we have seen from the previous, like the breast, the lung, you see, as long as we use the immune checkpoint inhibitors, you maintain the response and sometimes get even a better response at a longer. So when your patient is responding at the beginning with the immune checkpoint inhibitor, we do suggest or we do think that the patient will continue achieving this response. And then why did we add the chemotherapy to the immune checkpoint inhibitors? So we all know that the immune checkpoint inhibitors is a very strong weapon that we have been using so long. But why do we add chemotherapy? Because when we added the chemotherapy, and this is extrapolated from the lung, that we allow more cell destruction, more protein exposure to the immune system, more tumor infiltrating lymphocytes, hence the improvement of the synergism with adding chemotherapy to the immune checkpoint inhibitors. And this was the keynote 522 trial, which we all know by heart, with using the immune checkpoint inhibitors with chemotherapy as neoadjuvant in triple negative breast cancer. And you can see the pathological CR, you get an improved delta of 14%. And as we know from other publications that the pathological CR is a surrogate marker for overall survival. And then did we find the difference? Because we all know, again, from all the studies, we all know that in the metastatic setting, you need to look for the PD-L1 positivity. And then we do have in the lung, when the higher the PD-L1, the better the response. Did this differ in the neoadjuvant setting of triple negative breast cancer? Actually, no. So you look at the delta improvement in the pathological CR rate by 14%, and then in the PD-L1 positive and the PD-L1 negative, actually the delta difference of 15%. So we don't need to measure the PD-L1 status or the PD-L1 concentration in the neoadjuvant setting. As you can see, the event-free survival at 3 years is a gain of 7.7%, and by pathological CR, definitely the pathological CR was higher than the not achieving the pathological CR. Then for the overall survival, you still get a minor benefit with a hazard ratio of 0.72. Yet not that impressive, but we do get an improvement in overall survival. But then comes the question. So you gave the patient your neoadjuvant, and then you are continuing on pembrolizumab as adjuvant treatment. But then the patient is scheduled for radiotherapy. Would this affect the radiotherapy? Should I stop the radiotherapy? Or should I stop the immunotherapy, give the radio, then continue? Actually, this was thoroughly looked at. And the Society of Immunotherapy of Cancer said, please continue your immune checkpoint inhibitor with the radiotherapy with no added side effects or grade 3 to 4 toxicity. And if you looked at the guidelines, high-risk triple-negative breast cancer, you need to give the preoperative pembrolizumab combined chemotherapy, and then you continue the adjuvant for 1 year. What about the metastatic setting? We do have the Keynote 355 with pembrolizumab plus chemo versus placebo plus chemo, and you do get a benefit of overall survival of 7 months, which is really impressive in a metastatic triple-negative patient breast cancer, and we are scared from this triple-negative. If you look again at the guidelines, you find that if the CPS score is more than or equal 10, it is category 1 to use the pembrolizumab plus chemotherapy. However, if you get less than 10, please use chemotherapy alone and don't add the chemotherapy. So we have to differentiate between the neoadjuvant and the metastatic setting. But then don't forget that we do get the side effects from using the immunotherapy. What are the side effects? Please put itis, we have to excite anything you want to put. You get all over inflammation all over the body, because this is a crazy immunity that is uncontrolled and could lead to autoimmune attacks with the neurologic, the eye, the heart, and the lung. And there is a pattern for the immune-related adverse events. The rash are the most common at the beginning, and as long as you go with the immune checkpoint inhibitors, we do get pneumonitis. And I had a patient who received the adjuvant pembrolizumab. Then at cycle 7, at the adjuvant setting, she was admitted to the ICU, and I believe my colleague Dr. Baheya will show us this case in details. What about the ADCs? We've been talking all day about the ADCs, and we heard about the ADCs. So we do have, so the idea behind the ADCs, you get an antibody, you conjugate a chemotherapy to it or a payload that is released in the cancer cells. So we do have many ADCs. Against the anti-HER2, I'm not going to talk in details. Trastuzumab deruxtecan in comparison to the TDF1, the difference is you have a better payload at 8:1. One of the most beautiful things is the idea is that we don't need the antibody. It's the trick here is the payload itself. So whenever you put a better payload, you get a better response. And then they discovered that the mode of action, there is something called the bystander effect. Bystander effect is when the cells are destroyed by the antibody drug conjugates, the released payload will attack the neighboring cells. And this was, I'm not going to go because we said this many times regarding the trastuzumab deruxtecan, it HER2 low, and as you can see, it is category 1 prepared in the most recent NCCN guidelines. What about the anti-TROP2? What is the TROP2? So we get this antibody drug conjugate with a linker, and then it has a payload of a topoisomerase 1 inhibitor. So what does it do? Exactly like the trastuzumab deruxtecan, but it attacks the TROP2 and not the HER2 receptors. So it gets sorry, I have. Okay, so again, we do have the bystander effect, and we know all the sacituzumab govitecan with the ASCENT phase 3 trial showing us the improvement in progression-free survival and the improvement in overall survival. Again, looking at the NCCN guidelines, you get the sacituzumab govitecan as category 1, but take care in those triple-negative patients. We don't know the proper sequence. Should we go for the trastuzumab deruxtecan and HER2 low, or should we go for the sacituzumab govitecan? We don't know that. Actually, there are ongoing trials. The combination of pembrolizumab with sacituzumab govitecan in hormone receptor positive, which was a positive trial for progression-free survival and overall survival. What about the datopotamab? The datopotamab is another anti-TROP2, and as you can see in this waterfall curve, you can see the decrease the size in the cancer mass size. What about the patritumab? So now we're looking at the HER3. So we left the HER2, we left the TROP2, and now we're getting a new target, which is the HER3. What is HER3? So HER3 is another human epidermal growth factor receptor that actually can be activated by 3 mechanisms, either heterodimerization with the HER2, or binding with a growth factor, or spontaneous activation. And actually, it was found out that it's highly present in breast cancer. So at the end of my slides, this slide, I'm summarizing what are we talking in the future. So if you look at the monoclonal antibodies, you'll find the patritumab and a lot coming in the pipeline. And then, interestingly enough, we all heard about the BiTEs, the bispecific T-cell engagers, which is booming in the hematology. And actually, we do have those in breast cancer nowadays, like the donigotuzumab and the pertuzumab with pertuzumab. So those bispecifics are still in the pipeline. They are booming in hematology, but yet we're waiting to see them in the solid tumors. So to conclude, breast cancer is a heterogeneous disease, and there is no role at all for one size fits all. Combination of immune checkpoint inhibitor and chemotherapy, I showed you, it has a synergism. Antibody drug conjugates are highly used nowadays, and we now do have a subgroup of triple negative breast cancer. But again, we need still more data because the data is immature, how to put to sequence the treatments that we do have. And thank you so much. Always discuss your cases in MTT. Thank you so much.
Thank you, Professor Ahmed, for this very comprehensive lecture.
It's my pleasure to introduce Dr. Sarah Shams, lecturer of clinical oncology at Asr Al Aini Faculty of Medicine. She will introduce a title about benefits of hormonal treatment of ductal carcinoma in situ.
The audience, we are going to discuss ductal carcinoma in situ in this session in the area of hormonal treatment. Before the routine screening program by mammography, ductal carcinoma in situ was rarely detected. Now, it accounts for 20% of breast cancer diagnosis. Most of these patients have microcalcification, no palpable breast mass on their mammography. This figure shows types of breast cancer, with the ductal carcinoma in situ presenting 20% of the breast cancer newly diagnosed cases. The last 30 years, incidence and treatment of ductal carcinoma in situ have increased without a real decline in the incidence of invasive breast cancer. This trend in the age-adjusted incidence of ductal carcinoma in situ and the invasive cancer from 1975 to 2005 was 1.8 versus 32.5 per 100,000 cases. May this suggest overdiagnosis and overtreatment? Ductal carcinoma growths are confined to the inside of the breast milk duct, no infiltration of the basal membrane, with 70% of the ductal carcinoma in situ are ER and ER positive. Despite being a pre-invasive cancer, it has been treated like an early-stage invasive breast cancer. Since treatment of a ductal carcinoma in situ after surgery doesn't improve survival, is ductal carcinoma in situ overtreated? The main treatment for ductal carcinoma in situ, as we all know, is surgical treatment. Can be breast conservative surgery and followed by radiotherapy. That's going to depend on size of the lesion, relation with the mass of the breast, and the respecting the patient wish. And or mastectomy. Indication for sentinel lymph node was the large area of calcification breast mass, and the mastectomy because sentinel lymph node dissection in subsequent surgery cannot be done if needed. The pathology report for ductal carcinoma in situ surgery must include those factors because it's importantly to classify the risk, the size of the lesions, the histological grade, the presence of a necrosis, architecture pattern, distance to the closest margin. The adjuvant treatment for stage 0 breast cancer. Adjuvant radiotherapy effect 10-year gain, 15% of ipsilateral breast event. As shown here, there's 5-year gain and 10-year for 10.5% and 10-year gain for 15.2% for breast conservative surgery, which followed by radiotherapy. No overall survival benefit. Can we define a subgroup of ductal carcinoma in situ to omit radiotherapy? Randomized controlled trial in both menopausal women and mass 2.5 centimeter pre-margin grade 1, 2 surgical only, compared in a low or intermediate grade BCIS compared to the high grade. Local recurrence rate was 1% per year. And this cohort can be defined as subgroup for omission of radiotherapy. Is the treatment side effect of a hormonal therapy outweigh its benefit? A meta-analysis of a post-trial for the tamoxifen reduction in the post-ipsilateral in situ recurrence with a hazard ratio 0.75 and contralateral in situ recurrent relative risk was 0.5. Ipsilateral invasive carcinoma trend toward lower risk with no significant difference. Hazard ratio 0.7. Contralateral invasive carcinoma risk recurrence was 0.5. No overall survival benefit as shown here for an SAP-25 trial and the UK NAS trials. The ipsilateral DCIS and the contralateral DCIS recurrence and the ipsilateral invasive, contralateral invasive. It's importantly, at 10-year follow-up, the ER positive DCIS who received tamoxifen had significant decrease in any subsequent invasive, non-invasive ipsilateral contralateral breast event with a hazard ratio of 0.58 compared to placebo. And this long-term effect should be maintained if we are considered the escalated treatment like we're going to see in the further trials. Is there another option could be offered as a hormonal therapy for DCIS? Yes, it AIPS and SAP B35 trials showed anastrozole as a non-inferior to the tamoxifen, but again with no overall survival benefit. But it has a different toxicity profile, as was mentioned by Dr. Amir and Dr. Luay. The hormonal profile and hormonal toxicity from the hormonal therapy for the patient, as regarding thromboembolic events or endometrium risk or AI for bone health, should be closely monitored for the patient under hormonal therapy. Can we offer lower dose of the hormonal therapy to modify the quality of life and maintain the benefit from the hormonal therapy in the DCIS? The randomized placebo-controlled trial of a low-dose tamoxifen to prevent local and contralateral recurrence in the breast intraepithelial neoplasia in 2019. It was a single trial that used the tamoxifen 5 milligram for 3 years versus placebo. And in this trial, that tamoxifen was this dose and this short duration was not compared to the standard arm, which is tamoxifen for 20 milligram. This single trial showed a recurrence rate was 5.7 versus 11.9 for the tamoxifen 5 milligram for 3 years versus the placebo, with a median follow-up of 5 years, similar to that with higher dose. But of course, it was less toxicity, and there was maintained benefit with longer follow-up at 10 years for this trial. As shown here, there's a benefit from a tamoxifen versus the placebo, even the lower dose, the 5 milligram for the short period, which is 3 years, cumulative breast cancer incidence %. And the cumulative contralateral breast cancer incidence rate was also there's a beneficial with the for a reduced dose and a short duration. Side effect, recently published side effect of low-dose tamoxifen results from a 6-arm randomized controlled trial in healthy women, cancer-free. It was a healthy women that was randomized to different lower dose of tamoxifen, and there was the endpoint was as a chemo prevention. In this trial, the healthy woman was randomized for 6 months of daily 20, 10, 5, 2.5, and 1 milligram of tamoxifen or a placebo. And there was a non-inferior magnitude of decreased breast density in the follow-up mammography for this woman was seen with the lower dose. Lower dose was associated with less side effect and given a new insight for the future dosing strategy if we are considering it in an adjuvant setting for DCIS. Also, tumor profiling test. We know some cases of a DCIS will transform to invasive cancer with estimate from 20 to 50%. Can we better predict those who are at high risk by tumor profiling test? Tumor profiling test like Oncotype DX to predict a local recurrence or breast DCIS score or decision radiotherapy to predict a local recurrence and the radiotherapy benefit. Molecular signature in ductal carcinoma in situ, a systemic meta-review and meta-analysis was published for 5 trials, which included 3,478 ductal carcinoma in situ patients who were treated who was tested for molecular profiling to assess the benefit of the radiotherapy. The risk prediction of a molecular signature is independent of other risk stratification tools. The risk prediction of a molecular signature have tendency toward a radiotherapy de-escalation as part of a treatment de-escalation for a DCIS. but still it's not the standard of care. Before screening program, DCIS was rarely detected, but today DCIS account for 20% of breast cancer patients in our practice. The primary role of systemic treatment to reduce the risk of a recurrence in ipsilateral and/or contralateral breast, but the side effect of the hormonal therapy may outweigh the benefit. Also, it can be challenging regarding the patient compliance with the standard treatment dose, the 20 milligram, and the 5-year period. The prospective randomized trial to evaluate the efficacy and the side effect of the verifying dose regimen, the reduced dose, so tamoxifen is needed with longer term of 10-year follow-up. The scientific literature suggests that molecular signatures are a promising tool for finding the balance between over and under treatment for the DCIS patient, but further study are needed to assess its impact on mortality. Thank you.
Thank you very much, Dr. Sarah, for this very nice presentation. And now to the next speaker.
Last but not least, Dr. Omnaya Muhammad. She is a specialist medical oncologist at Baheya. She will discuss case discussion. Please, doctor.
Good evening, dear professors and colleagues. My name is Omnaya Muhammad, Assistant Lecturer of Medical Oncology at National Cancer Institute, Cairo University. It's my pleasure and deep honor to be invited by dear professor and mentor, Dr. Amani Hilal, to give a case presentation titled Triple Negative Breast Cancer, the Black and White. Our case is about young lady, 36 years old, married with 2 offspring. The youngest is 7 years old. She is medically free with performance status 1. She has negative family history. She is premenopausal with regular menses and never used oral contraceptive pills. Her present complaint was left breast mass for 2 weeks duration, for which she sought medical advice, where her doctor had examined her and found left breast mass 4 by 4 centimeters, well defined, and there is no axillary lymph node felt clinically. Before proceeding to the investigation section, we should highlight that it's very important to give your patient time to listen from her and the complete history taking and good and thoroughly physical examination. This will guide you to select which indicated investigation to be chosen for this patient, and of course will save the patient time and the money. Our patient had sonogram that showed left breast lesion by red cord, and there is non-specific axillary lymph node. Contrast enhanced sonogram showed confirmed that it's solitary enhanced mass, and the biopsy taken from the breast lesion showed invasive duct carcinoma grade 3, ER negative, BR negative, HER2 positive, HER2 equivocal score 2, and turned negative non-amplified by SISH. KI6 level was high, 70%. Patient had PET and showed only focal lesion in the left upper inner quadrant of the breast 2 by 8 centimeters, SUV 9, and there was no metabolic active any lesion. Her labs were within the normal range, and the echo was normal study ejection fraction 73%. The patient was discarded at the NDT. And as we all know, that every new case of that breast cancer should be managed and discussed at the NDT, and this reflects on the outcome for the patient. And according to the NCCN guideline, the best treatment option for oncology patient is all enrollment in clinical trial. So, the question to my dear professor and the panelists. We have young lady, early triple negative breast cancer, medically free, and to your knowledge, she had health insurance that will cover every treatment option, even so, what do you recommend for this patient? Would you offer her upfront surgery or neoadjuvant chemotherapy, either anthracycline taxane, dose dense, or taxanes and carboplatin? Which option? Would you combine immuno with chemotherapy, or you have other recommendations?
Before answering this question, which is the answer is obviously number 3, I want to ask, is PET-CT routine in this patient? So I want to ask the professors, Professor Hiba Zawahri and Professor Amani Hilal and Professor Luai, do we do PET-CT, and Professor Niveen and Professor Muhammad Sabri, do we do PET-CT routine in this case? There's no. So why did you do this?
But the patient at this point, she already have sought medical advice, taking the biopsy and doing a and then we have met here.
تاني الدكتورة إيمان مادام حضرتك raise problem of PET, the very proper thing is to ask for bone scan. These patients, according to ASCO guideline, young with lymph node in axilla and triple negative. So mandatory baseline bone scan. PET-CT can be offered, usually asked by the patient and she have insurance, but this is not mandatory.
Dr. Iman, I think your question, Dr. Iman, is very intelligent about this case, but this case is a premenopausal patient with a late bit sizable disease. She have 4 by 4 centimeters tumor size. So it's better to staging for these patients meticulously, because if she metastatic, she will not eligible to receive anti-PD-L1 without making CPS score more than 10. And if she's not metastatic, you're eligible to give her chemoimmuno even without PD-L1 assessment. That's why the importance of PET-CT, it may consuming of the finance, but in the reality, you are allowing to give her neoadjuvant without PD-L1 suppression if she's not metastatic. That's why I think the PET-CT is valuable in this situation.
Okay.
Let's revise this algorithm proposed by the ESMO for treatment of early triple-negative breast cancer. For breast lesion lower than T1C, we can go for upfront surgery. For T1C and 0, we should give neoadjuvant chemotherapy. And if the patient achieves complete pathological response, she will put on follow-up only. And if there is no pathological response, if she is BRCA mutant, she will benefit from olaparib adjuvant for 1 year. If she has residual disease, we can follow the CARIAT-X trial and give her adjuvant capecitabine, or maybe considering immunotherapy or enroll her in a clinical trial. If the patient has tumor larger than 2 centimeters, like our case, she would benefit from combination IO and chemotherapy. And again, if she achieves complete pathological response, she may benefit from continuing pembrolizumab for 1 year. And if no pathological CR, we will consider if the patient is BRCA mutant, she will be offered olaparib. If she is not, we have 2 options, either IO or capecitabine, and again, to enroll her in a promising clinical trial. As we all know, the ultimate goal of treatment is to achieve complete pathological response, which is a surrogate marker for disease-free survival and overall survival. So let's review the evidence and think how to improve beyond the standard. We may combine chemotherapy with platinum component. We may combine chemotherapy and immunotherapy, or add olaparib maybe for high-risk patients. Reviewing the literature, we found that many phase 3 clinical trials showed the benefit of combining immunotherapy with chemotherapy in early triple-negative breast cancer, mentioning the keynote 522 trial. When adding pembrolizumab to chemotherapy raised the PCR rate, and which was reflected to the patient outcome. As Dr. Sabri mentioned, it's regardless the PD-L1 status. In neoadjuvant, we can use it regardless the PD-L1 status. And why the triple-negative cases benefit from adding immunotherapy? As we all know, the triple-negative is the highest mutation load among the breast cancer subtypes, and it has the highest tumor infiltrating lymphocytes, which is correlated to the outcome. In the last figure, we can follow the red line, the dotted one and the straight one. Both are triple negative case, the same stage, not positive, while the case that had still more than 30% had better outcome. Okay, the famous keynote 5-2 trial showed that the patient with triple negative can be randomized either chemotherapy, carboplatin, taxane with pembrolizumab followed by anthracyclines, chemotherapy, and also pembrolizumab, or the other arm is immunotherapy free, and both was subjected to surgery. And the keynote 5-2 showed that combining immunotherapy with chemotherapy had great benefits for the patient regarding the event-free survival and the major reduction in distant recurrence with adding pembrolizumab. Back to our case, the MDT decided for the patient to have clip insertion and vortex insertion and start new adjuvant. The protocol adopted by keynote 5-2 trial where they start with taxane with carboplatin and immunotherapy, followed by anthracyclines and immunotherapy, and then to go to the surgery. As our patient was young and premenopausal, we added monthly Zoladex. And the patient started her treatment, Taxol carbo with pembrolizumab, carboplatin area under curve 5, day 1, taxane 8 milligram per meter square, day 1, 8 and 5, with 200 millimeter of pembro. And she had refractory vomiting all through the chemotherapy cycle, even with antiemetic support and antipsychotics and steroids. Of course, she had suffered hair loss and had easy fatigability and weakness also. And the most serious side effect was the colitis and diarrhea. Our patient had grade 3 to 4 diarrhea, which necessitated admission to ICU and the ICU to correct the hypokalemia and hypotension and electrolyte disturbance twice. So why is immunotherapy toxicity is stressful for the treating physician? One of my dearest mentors had learned me and lesson and will share with you that each oncologist can prescribe chemotherapy or immunotherapy, but the good oncologist is the one who can deal with the side effect and manage it. And the clever one is the one who can predict and prevent the side effect. So as we all know, the chemotherapy profile is good predicted. Almost all the patient will suffer from some sort of toxicity, which is predicted, and organ specific, and the time will be predicted also. As we know, stomatitis or meningitis is early. Vomiting may be early or delayed. Hematologic toxicity mostly around day 10, which is the nadir. So it's predictable. But when we talk about immunotherapy, it's totally unpredictable. It's not organ defined. It can occur during the treatment or even after cessation of the immunotherapy. The toxicity varies a lot. It can affect every organ in the body, starting from the mucositis, thyroiditis, either hypo or hyperthyroidism, rash, vitiligo, pneumonitis, hepatitis, pancreatitis, pericarditis, neuritis, every organ could be affected. And in very varying degrees of toxicity, from mild to moderate and life-threatening. Also, it could be managed easily, supportive, or we may need steroids or infliximab, or sometimes to stop the immunotherapy. It's known for most of us as ICE syndrome, as mentioned by Dr. Ahmed. And the most important point that we should learn our patient the earlier signs and symptoms of all these side effects. So whenever he notices or the caregiver notices any sign, she should contact her physician. Okay. There is a study published in Lancet showing that immune-related adverse events in phase 3 trials for triple-negative breast cancer patients, the commonest side effect was in form of endocrine affection, either hypo or hyperthyroidism, which is long-lasting. The immune-related side effect is either acute or chronic. The GI symptoms, stomatitis or diarrhea or enterocolitis, mostly acute and resolved, but the endocrinopathy usually lasts and turn into chronicity. So how we will manage the immune-related side effects? We can divide it either acute or chronic. and according to the severity, mild or life-threatening or organ-specific. So if we have fatigue, dry mouth, arthralgia, myalgia, which is mostly mild symptoms, we can safely continue the treatment and support the patient. But if we have colitis, hepatitis, pneumonitis, which is usually more than grade 2, we should pause the treatment for a while and give the patient supportive treatment and maybe destroy it. If the symptoms regress below grade 2 toxicity, we can resume the treatment. But for some vital organs like brain or heart, if the patient develops encephalopathy or myocarditis, we should stop the treatment forever. And it goes without saying, if there is any grade 4 or persistent annoying severe toxicity, we should stop treatment also. Quality comes first. We have to respect the quality of the patient. Back to our case, the patient had grade 3 to 4 adverse event in form of vomiting while she is on chemotherapy, neutropenia and diarrhea, electrolyte disturbance, hemodynamic instability, and hospitalization twice while she was on anthracycline and immunotherapy component, which was persistent and even with supportive treatment, steroids and antiemetic growth factors and IV fluid. So the entity decided to omit the last cycle of anthracyclines and immunotherapy and send the patient for the surgery. The patient underwent left wide local excision and axillary clearance, and the post-operative period went smoothly. And thanks God, the pathology came with a good news, and our patient achieved a complete pathological response. But it is not over yet. Knowing that the patient is BRCA positive, would you recommend continuation of pembrolizumab up to 1 year, or offering her olaparib, or being BRCA positive young female? Would you offer her risk reductive surgery, either mastectomy or bilateral salvagectomy? The discussion is open for you and the panel. Thank you.
هو ده كان سؤال ولا ده فعلا؟ طيب لا عشان الوقت بس هقول لك على حاجه ثانيه. انت ستيكي للجايد لاينز اوكي؟ وات اباوت فاينانشال توكسيستي اي او
موجوده بقوه مع الاي او كومبايند مع الكيموثيرابي، بس البيشنت دي كانت سبورتد يعني هيديها هيلث انشورنس
سبورتد بروجرام. اوكي دكتور صبري انا عارفه.
Thanks, Dr. Omnay, about your elegant presentation. Thank Dr. Omnay Amani Hilal to invite me for this session. And my question for Dr. Shaimaa. Dr. Shaimaa, yes, about Keynote 522, and you can share answer with Dr. Omnay about the design of Keynote 522. You know that Keynote 522 is not allowed to give a drug in addition to Pembro in the adjuvant setting. You know that we're receiving chemotherapy plus immuno, and for adjuvant treatment, the study have two arms for placebo and another arm of to give Pembro alone without capecitabine. Although we see in the many guidelines in the ESMO or San Antonio or ASCO guidelines, they put a Pembro plus capecitabine in the adjuvant setting. It's not the design of Keynote 522, because in the Keynote 522 you have only Pembro for an adjuvant setting for 9 cycles to complete 1 year of Pembro, and in the 2 years later there is a CREATE-X trial highlighting capecitabine for the patient not achieving PCR to be an adjuvant setting. So it's not allowed to combine both trials in both each other, except it is expert opinion. I'm agree to give Pembro plus capecitabine for the patients not achieving PCR. But to highlight it, that is not a design of Keynote 522. The Keynote 522 is giving only Pembro for the adjuvant setting, and the benefit for the patient not achieving PCR is there over the patient achieving PCR to give Pembro alone. So Pembro plus capecitabine is not the design of the trial. It's a both trial, CREATE-X and Keynote 522. The same as continuation of the neratinib post CD1. There is no neratinib post CD1. There neratinib post trastuzumab as extended treatment for as extended trial 10 years ago for the patient for hormonal post disease. There is no neratinib post CD1. there is nothing post-trastuzumab. So I want to clarify this big difference between expert opinion based on multiple trials and to keep with the trials as it designed in the original design.
Of course, I agree with you, Dr. Muhammad. Whenever we start the treatment according to trial, we stick to the trial. We don't combine that line of
Yes.
trial. We should stick to
Yes.
the trial we have started.
Yes. And my next question to Dr. Rai about the extended hormonal treatment. Dr. Rai, you know that in soft trial and text trial, we have 12 years of follow-up of those patients. If you meet this patient today, you will prescribe for her either ribociclib for an adjuvant treatment or abemaciclib for endo disease. That's why I can see that extended hormonal treatment is far away from this now, because we are following the patient receiving ovarian castration plus AI or exemestane as soft trial or Taylor's X away from the currently patient population receiving abema or ribociclib as an adjuvant. Do you agree to extend the hormonal treatment for those patients?
So a very important question, yet difficult to answer. To extend or not in premenopausal patients who completed the 5 years of LHRH agonist plus endocrine therapy, in addition to 2 to 3 years of CDK4/6 inhibitor. That's the question, right? First, I think that the benefits of endocrine therapy might be a little bit different from the difference achieved by adding the CDK4/6 inhibitors. So there might be some patients who benefit, who still have additional benefit of the extending the adjuvant therapy, even if they did receive the CDK4/6 inhibitor. And those are probably among the high nodal burden patients, those who are very large tumors or 4 or more positive lymph nodes. So I would consider that in very, very high risk. Hopefully for us, this question will be asked after 3 to 4 years from now, because now we don't have any single patient who have received 2 to 3 years of CDK4/6 inhibitors and completed the 5 years yet. The main player about the decision is the tolerance of the 5 years of endocrine therapy plus the CDK4/6 inhibitor. So I have a high risk patient who is tolerant to the 5 years. ساعات بنلاقي بعض العيانين بنشوفهم كتير حتى في القصر العيني يمكن انه خلصنا ال5 سنين ونقول لهم مبروك انت خلصت. تيجي بعد 2 3 تقول انا تعبت جدا بعد ما وقفت العلاج. اروماتيز انهبيتورز خلصت 5 سنين وتقول انا تعبت جدا بعد ما وقفت العلاج ده. طبعا يعني ما فيش withdrawal ولا حاجه، لكن this is a very clear indication of how tolerable her adjuvant hormonal treatment was. ده على عكس 50 الى 60% من العيانين اللي ما بيستحملوش خالص وبيضطروا حتى يوقفوا اثناء ال5 سنين. فلو كانت عيانه من دول اللي هي مبسوطه قوي بالعلاج ل5 سنين و very high risk, I would consider extension.
Thank you, Dr. Rai.
Thank you for all, and now we close our session. Thanks.
شكرا جزيلا لحضراتكم. ان شاء الله احنا هنكمل على طول last session for today the MDT session. احنا بس هناخد 5 دقائق وحضراتكم موجودين، بس لو هنرجع ورا بس صفين عشان نعمل السيت اب بتاع ال MDT في 5 دقائق، وان شاء الله نبدا على طول باذن الله. هستأذن البانل ممبرز كلهم يقعدوا في الراوند تيبل. اليو شيب تيبل، هستأذن كل البانل ممبرز يتفضلوا. انتوا هتقعدوا او انتوا واقفين انتوا الاربعه، او حتى بص اشرف خلي في ترابيزه لل لا اطلع هنا. ما انا اقول لك خلاص يبقى خلي في ترابيزه هنا، خلي في ترابيزه هنا. حضرتك جاهزه؟ في كراسي ثانيه يا الناس اللي واقفه دي كلها لها كراسي. فريق راديولوجي كله، فريق الاشعه كله. اه لا هنا في الممبرز، بانل ممبرز. محمد استاذن كل البانل ممبرز يتفضلوا في اليو شيب سيت اب. دعاء محمد، دكتور حسيني، دكتور محمد، دكتور حسيني. بقول لك لو حسيت بالعدد بدأوا يظهروا فريق الاشعه ده. لا زود ورا وزود هنا كمان ترابيزه وكرسي، ترابيزه وثلاث كراسي. يلا دلوقتي هنا وهنا، هنا وهنا. وهناك برضه في واحده ده. عليك الدور ولا هم عليك؟ معانا احنا نحركهم على الباك. right. عايز اديهم ميه. مش معانا على 5 من واحد. Yeah, yeah. نفس الوقت مش كراسي ليها. وده عشان لو حد سأل وانا هجيب لك مايك تاني دلوقتي.
Hello.
بسم الله الرحمن الرحيم. We will start the last session for today. And the last session is today the MDT, the multidisciplinary approach in cancer management. Today we have 3 cases. We have our presenters for the first case, Dr. Amira Hamid, Dr. Basant Ahmad, Dr. Ashraf Naguib, Dr. Ahmad Hussein. They will start the presentation and we will go for discussion with the panel. And finally, we will vote about any conflict of the decisions by yes or no. Thank you.
Bismillahirrahmanirrahim. I'm honored to begin the first presentation about a case of recurrent breast cancer. الشاشة هنا. First case of patient with recurrent breast cancer with my colleagues, Dr. Amira Hamid, Dr. Basant Ahmad, Dr. Ahmad Hussein, and me, Ashraf Naguib. دي 28 years single menopausal female, particular menstruation. Single female regular menstruation, medically free, surgical history tonsillectomy, family history, grandmother with breast cancer. Patient came in the clinic in February 2022 with complaint of left breast lump for 1 month. Clinical, she was left breast lump lower outer quadrant mass, 4 by 5 centimeters fixed to the chest wall, with mobile axillary lymph nodes 2 by 2 centimeters, staging T4A N1 M0.
The patient was referred to the radiology department to do the mammography and the initial ultrasound. On the 2D mammography, we can all see the mass in the left breast. It's outer central, and it was deeply seated in the deep third of the breast, zone C. and it was of equal density and irregular outline. It was a suspicious mass that we considered doing contrast enhanced mammography to exclude other lesions within the same breast. It displays a heterogeneous mass enhancement, and it was located 8 centimeters from the nipple. On ultrasound, the mass appears as lobulated, irregular, and surrounded by a desmoplastic reaction, which is of suspicious nature, and it shows no significant internal vascularity or vascular assessment, and the size of the mass was about 32 by 21 by 24 millimeters. This mass was biopsied and referred to the pathology department.
A through-cut needle biopsy was submitted to the department from the left breast mass. 3 cores, each measured 1 to 1.3 centimeters long. It revealed invasive ductal carcinoma grade 3 with no identifiable DCIS component nor lymphovascular permeation. Immunohistochemistry done to identify the hormonal profile and reveal the triple negative breast cancer. Also, a fine needle aspiration from the left axillary lymph node revealed reactive hyperplasia and was negative for metastasis.
Okay, so after going to the MDT, the decision was going for clipping, followed by neoadjuvant treatment, and after that, we would go for wide local excision and axillary clearance. So based on the brightness trial, which I guess most of us know, we decided to go with carboplatin as it showed some significance in increasing the overall survival a little bit, and also increasing the rate of pathological complete response. So we started neoadjuvant treatment on March 2022. We wanted to start with pembrolizumab, of course, because it was the standard of care. However, it's not available at our center, so we decided to go to the first in the line, which was dose-dense AC for 4 cycles, in addition to monthly goserelin 3.6 milligram. So after the first 4 cycles, we did some clinical assessment, and it showed a weak response. The initial mass was 8 centimeters, if you remember. However, the new lump was 6 times 5 centimeters. And also the patient had neutropenia after each cycle of the first 3 cycles of AC, and we had to postpone each one of them for 1 week. However, there was no neutropenia after the 4th cycle. Followed by paclitaxel carboplatin for 4 cycles every 3 weeks, in addition to a granulocyte colony stimulating factor, which showed some good response as the lump decreased to 3 and 2 centimeters. So we decided to go outside of the guideline for a little bit and try to give an additional 2 cycles of paclitaxel carboplatin.
On post-neoadjuvant mammography and contrast-enhanced mammography, a marvelous response was found. The mass has almost completely disappeared, with marked by the clip. And regarding that, we started the initial assessment by contrast-enhanced mammography. Another contrast-enhanced mammography was done to assess the response. And as we can see, there are no significant focal or non-mass or mass enhancement in the post-neoadjuvant chemotherapy. However, the complementary ultrasound shows that a few nodules were present around the residual distortion, and they were suspected to be fragmented parts of the initial mass, and both were localized by wires and referred back to the surgery department.
MDT after neoadjuvant chemotherapy was for surgery. by inserting two wires, one over the clip and the other over the most distant nodule for guiding to wide local excision and sentinel lymph node biopsy.
In the pathology department, we received two specimens, the wide local excision specimen that was oriented for margins and was by gross inspection, it was unremarkable. On serialing, there is an L-defined area only measuring 0.7 by 0.5 centimeter. The surrounding tissue clearance ranging from 1 to 4.5 centimeter. The sentinel lymph node was dissected and yields 9 lymph nodes. On microscopic examination, there is an only invasive residual viable focus measuring 0.5 by 0.5 centimeter. The resection margins were free, no residual DCIS, nor lymphovascular permeation. The sentinel lymph nodes were negative, and a repeat of ER was done and revealed a negative results.
So we decided to go for the adjuvanted treatment according to the Koreatix trial, which showed some marvelous response to the carboplatin. And as you can see, regarding the disease-free survival and the overall survival, there is an early separation of the two lines. So we decided to go with capecitabine 1,000 milligram per meter square twice daily for 8 cycles, starting from December 2022. And that was preceded by the BRCA testing, which was negative. And in addition to that, we decided to give monthly goserelin because the patient, if you remember, she is 28 years old and she's still single, so she wanted to have some fertility preservation. And she had post-operative radiotherapy between November and December 2022. So the patient finished capecitabine Xeloda in June 2023, and the plan was regular follow-up every 3 months.
In the first follow-up in August 2023, patient came complaining of left retroareolar lump. By clinical examination, it was left lower outer quadrant 5 centimeter lump with another 9 o'clock 3 centimeter lump. This complaint was just about 8 months after the surgery. Masses are close to the skin with the skin thickening over lower outer quadrant, over quadrant 1, likely radiotherapy effect.
On this event, they sent the case for our department for another mammogram. On the mammogram, we can see the newly developed mass, which was not appreciated in the post-neoadjuvant images. The upper images are of the new or the post-recurrent masses. We can see the mass as obscured equal density mass or masses in the lower outer quadrant. On the post-neoadjuvant, there were no densities at that site. And also the contrast, if you remember the images, there were no enhancing lesions. This was considered as a recurrent breast that we did an ultrasound, and it shows lobulated, although defined, but it's still a suspicious mass that we biopsied.
The core biopsy from the recurrent mass showed a highly aggressive tumor, recurrent invasive ductal carcinoma that's lacking the ductal differentiation, marked nuclear pleomorphism and active mitosis, no DCIS detected nor lymphovascular permeation. Cytokeratin was done to confirm the epithelial nature of such tumor, and the hormonal profile still triple negative breast cancer.
NCCN guidelines for treatment of local and regional recurrence. In the case of local only recurrence, the initial treatment with breast cancer surgery plus radiotherapy was to do total mastectomy with axillary lymph node staging if level 1 and 2 axillary dissection not previously done. So the MDT decision for this case was for completion left mastectomy with tissue expander insertion for delayed reconstruction. Skin sparing mastectomy would be an optimal option for her age, but cannot be done as the largest mass was near to skin by 2.5 millimeters.
The received completion mastectomy specimen showed on serial link showed 3 firm grayish-white tumor masses ranging from 1 to 2 centimeter in maximum dimension. This masses was 0.2 centimeter from the overlying skin and 1.5 centimeter from the least deep resection margin. Microscopic examination of these 3 tumors showed invasive duct carcinoma that in some foci showing ductal differentiation and the other is very undifferentiated with bizarre nuclei and active mitosis. The resection margins were free with no few lymphovascular emboli were identified and wide areas of necrosis was noted. Cytokeratin is repeated on the specimen and revealed a positive result confirming the epithelial nature of such undifferentiated tumor. Also, GATA3 showed weak positive reaction. Synaptophysin was done and was negative in tumor cells.
So I won't let you cheat from the NCCN guidelines. Let's save it for later because to save some time for the discussion. I would like to summarize the case before we start the questions. It's a 28-year-old single premenopausal female. She had at first presentation a left invasive ductal carcinoma, grade 3, triple negative breast cancer. She received a neoadjuvant dose-dense AC for cycles, followed by paclitaxel carbo for 6 cycles, in addition to monthly Doladex, followed by left-wide local excision and sentinel lymph node biopsy, which showed IDC grade 3, T1 and 0 of 9 lymph nodes with residual tumor viability of 80%. BRCA was negative. She received adjuvant capecitabine for 8 cycles with port and Zoladex. She had local recurrence, which showed invasive duct carcinoma grade 3 with newly developed ER 20% 4/8. Remember, she was pure triple negative when she presented. PR and HER2 are still negative. She underwent left completion mastectomy with tissue expander for delayed reconstruction, which revealed a multicenteric IDC grade 3.
Thank you for the presenter, and we'll start the discussion from the MDT panel.
Bismillah ar-Rahman ar-Rahim. It's a great presentation by all those involved, Ashraf Naguib and his colleagues. There are a couple of things here, maybe not directly related to what will be after, but I just want to comment that in the original X-ray, especially the contrast, there was a lesion in the right breast that there was no comment about it, and that disappeared in the second contrast enhanced mammography. And the second comment is when you guys talk about family history, you say grandmother, the age matters as much as the relative who had breast cancer. So grandmother at the age of 60 means nothing. But if the grandmother had it when she was 40 or less, you might pay attention to it. So please always remember to talk about the age when you talk about the family history. And just really, these are the two comments outside it. Whether it is a recurrent or not, it is really a true recurrence because we have two types of recurrences, one at the scar and one away from the scar. Even if the histology is pretty much the same, it is considered a second event in the breast as it was away from the scar and will be treated as a new primary. There is one thing also in the presentation you did not talk about is, did you stage this patient at the whole body? Because once you get a recurrence, whether it is a true recurrence or a second tumor, you have to stage to make sure that there is no other systemic disease in this patient. These are the two comments that I just wanted to make. But I will leave the floor to Dr. Amani.
Actually, regarding the staging was done immediately after.
It is educational meeting, so we have to mention it to the people, even if you forgot it. We have to remind you when you get a recurrent, whether it's a new tumor or a true recurrent tumor, staging for the whole body is mandatory.
Just we diagnosed the patient with local recurrence, the whole body was staged for recurrence and was free.
I'm sure that's.
I want to ask about the neoadjuvant treatment. As you can see, we give the dose dense AC followed by, we don't have an access to the immune therapy, but we give 6 cycles of paclitaxel carboplatin. Do you think this was wise decision, or should we stick to only 4 cycles as the guidelines?
I believe it was a wise decision because we were responding. With the dose dense AC, we could expect that the patient would be responding. However, she was not responding well, only 2 centimeters, which is somehow stable disease if you compare with the RECIST criteria according to the 8 centimeter. However, when we used the Taxol or the paclitaxel, carboplatin, after 4 cycles, you went down to partial response or more than 50, I believe. I can't remember the numbers. So definitely it's wiser to continue as more as you have. Maybe the professors would help me here. If I go more further, because the guidelines would say give 4 and then refer to surgery. But when we gave the 4, she was still responding well, which was shown in the follow-up mammography. So this is why we went and extended the chemotherapy more out of the guidelines for 2 more cycles. Would you recommend that we did this? Do you support our decision, or would you stop at 4 and refer back to surgery?
Well, I always say, كلمة أحصل عدة. If the original plan was 4, it is 4, unless there is progression otherwise. So we stick to the original plan. That's what I will always say.
We'll hear from Dr. Gamal.
Standard of care is to give only 4 cycles Taxol carbo, regardless of the response of the tumor, whether responsive or not progressive, as far as there is no progression. Taking in care this patient, if there is residual, will receive Xeloda for 6 months, and giving 6 cycles of Taxol carbo will compromise the bone marrow to take 6 months of Xeloda. My comment here also about the timing of radiation. Most of the oncologists now prefer to give radiation first, then Xeloda, and not Xeloda followed by radiation therapy. But giving 6 cycles Taxol carbo, we don't have any data to support tailoring the treatment based on the response of chemotherapy in the neoadjuvant.
Sorry, I think we missed the Pembro from the start.
Yes, we
That's
don't.
why
We don't have
we are
access.
keeping with design of Pembro plus chemotherapy, which is 4 EC or for 12 weeks paclitaxel carboplatin biweekly, then followed by EC plus Pembro. As if we losing Pembro in our neoadjuvant setting, I think as if the tumor is responded for paclitaxel carboplatin, we should go for more vaccines, not exceeding 6 cycles. I know that the standard of care is 4 cycles. But this case is not
I
a
agree.
formal case with Pembro.
I would consider the dose dense AC as a treatment failure, and you could consider paclitaxel carboplatin as second line and give her the patient the full dose of the treatment just to push the patient to the BCR. This is the reason for giving the neoadjuvant. It's not the standard. It is just as a brainstorming with the patient. She's responding, so go until you reach the maximum response. Dr. Naveen wants to comment. Okay. Okay. Dr. Naveen will comment.
Here. First, at the beginning, you said that she was T4A because the tumor was extending to the chest wall, and you didn't do MRI. You did contrast enhanced mammography. So how did you evaluate the treatment response without the MRI? I know that we can do either or, but for this case, especially that she sticks to the chest wall.
I totally agree. يعني إذا كنت أنا هاخد فيها decision, I would have chosen MRI to identify. بس ساعات when the patient has a CT examination, we can depend on the CT for the chest wall invasion.
I'm sorry, I want to say something.
from my radiological point of view, from the beginning, this was multicentric. Why? Because after when they put the wire, they put it in 2 nodules, and this nodule developed during the patient on neoadjuvant chemotherapy. And by pathology, this 2 nodule was positive. I think from the beginning, from my impression, acute radiology, this is not recurrence, this is multicentric from the beginning.
That will lead us to the last question, please, because of the time. So forgive me for this. But how many surgeons here are keen when you have a patient under the age of 30 with 1 or 2 lesions, even if they are closed? How many of you would recommend mastectomy, even if these 2 lesions are closed in a patient under the age of 30? That would be yes and no question. That would be yes and no question.
No.
So there's almost unanimous decision that no, not for mastectomy, although we still say if you have a patient under the age of 30 and she has multifocal disease, even if they are closed and you decided to conserve this patient, please watch her very closely with further investigations, even not after 6 months, after 3 months, because the recurrence is always there in a young lady. So that just
Dr. Yazan wants to comment. Dr. Yazan wants to comment.
Dr. Yazan, just a little comment about the extending the chemotherapy. From a surgical point of view, we're not oncologists. We have a pragmatic approach. You extend chemotherapy if you cannot operate. If you can operate, there is no evidence that extending it, you're adding anything to the patient, because there is no evidence that giving 6 cycles will change their outcome. So extending that chemotherapy, if I was in the MDT, I would have put my foot down and operated on the patient. If they're operable, you go for surgery.
Can I argue?
Sure.
The region, why we are giving the triple negative patient a neoadjuvant treatment is to achieve pathological CR. And the patient is showing us that she's responding marvelously over 4 cycles. And that's why we, as you said, encourage to continue until 6 cycles. She might go into BCR.
So you give 8 cycles, we give 6 cycles. The most of your benefit is in the first 2 cycles.
Yes.
And if you don't have a significant change, then you are not likely to get that complete PCR.
The patient had significant change after 4 cycles. That's why we give. I want just to be sure I understand you.
So there was good response, but if you get a complete PCR, you usually see it from the first 1 or 2 cycles of that. So when you change, then you would have seen much better response. Extending for 2 other cycles will not get you a PCR.
Even radiologically, she was almost in CR.
But it wasn't PCR.
Yes, it's not, but what we are hoping to do.
Okay, so should we go to the surgical point? I have just a comment about the multifocality or the single lesion, because in the first contrast mammogram, it was a single lesion with the same picture of triple negative as Dr. Rasha always teaching us the same picture of the triple negative. And during the response, you have 2 types of the response, either the Swiss cheese response or the concentric response. In this case, it was a Swiss cheese response. So the residual disease to the clip, actually the clip, the tumor melted around the clip, and another focus. The next focus, yes, we put a clip on the both. On the clip, sorry, we put a wire in both, on the focus and on the clip, and we remove the whole area, and the margin wasn't. It was clipped. It was clipped. It was in the same place. So did you have any other options rather than wide local excision after neoadjuvant chemotherapy, Dr. Bahadir?
Well, it depends on the final pathology. If the pathologist, you have to review the slides with your eyes as a surgeon. If I see, not 2 foci, but also 3rd and the 4th, and then I may say that, yes, the margin is clear, but it is a probability that you may leave some tumor behind as well. So here comes the MRI. Of course, MRI is not a sure method to say that there's no remaining tumor. This lady is 28 years old. And when you complete the neoadjuvant treatment, it just from that point, from the surgery to the first recurrence, is maximum 1 year. That is sure less than 1 year, because you saw the lesion when it was 3 centimeters and 2 centimeters. So this can't be a secondary tumor. This is a tumor from the first. So it is not a secondary primary. This is the recurrence from the first disease. That's my opinion, of course.
So all of us as a surgeon agreed for the decision of wide local excision or in other approach?
Well, I can tell you that, of course, if you have a multifocal tumor, and if you're sure about it, if you can have a large margin, safe margin, you can do a breast conserving surgery in this lady, even she is 28 years old. What I think is that if this lady would live for 50 years, there will be a sure 90% of the time she will have a second tumor because she is so young. But here, the problem is not the recurrence. The problem here is the systemic recurrence, because this lady has a very bad prognosis. Now she has the recurrence. I don't think that this is only the recurrence in the breast. So the problem is not with the breast itself. So now you had the mastectomy, you made the salvage mastectomy, and it's good. I don't know what you've done to the axilla in the second surgery. Probably you didn't touch it. You
Yes,
do that second
yes, we don't touch
SLNE?
the axilla.
All right, that's okay. You may give radiotherapy if it's acceptable. Here, the problem with this lady is not the local recurrence. This is the recurrence in the systemic way.
So
one question. No. Bilateral? No, the other one is the expander. Still, we are putting expander before radiotherapy, or we can start to put the silicone and take a radiotherapy.
if I understand the question, actually we do mastectomy and tissue expander for the same side. Yes. Yeah, but the tumor, it was locally advanced. It was very close tumor to the skin, and the skin is irradiated. Actually, I do the tissue expander when I with my hands is it's clubbed. The irradiated skin is very difficult to be expanded easily. So it was a risk, but the patient is asking for even delayed reconstruction. So I can do skin sparing mastectomy in this situation. It is another issue. It's another issue. If the patient is asking for this, I will go for this. So last comment from the surgical point of view.
First, I am not against the decision of wide local excision and central, but for this patient is young. She's triple negative. She's locally advanced from the start, ST4, N1 or N2. So with the lack of immunotherapy, the Keytruda. So this is all of this will make me may suggest for the patient that she may have nipple sparing mastectomy and immediate reconstruction. So this is an option. I think the patient deserves to be discussed with, and it is by the way, I think this is a multi-site tumor from the start. So this is not a this is not a new tumor. This is a residual or a missed.
We agree, although it was in different centers, but to come to this, we have to move on. And it was a really good case to discuss. There were things I'm sure we all learned from it, but let's move on to next case. Thank you, Dr. Ayman.
Dr. Ashraf, last comment, please, Dr. Ashraf, about this issue, please. Because this lady, she missed an MRI from the start. Because she has a T4A disease.
Absolutely.
Any T4 disease should go for MRI because the MRI was superior in muscle intensity and also superior in the internal mammary chain involvement. So should we maybe Dr. Maybe for internal mammary chain, please, Dr. Raja.
This patient, she performed contrast mammography, and contrast mammography is not inferior to MRI. بالعكس, it is more specific than MRI in identifying multifocal we omit the false positives. The problem is in the chest wall invasion, and she was candidate for staging. So she performed CT, and we can omit the MRI. So long as we have a CT, we can identify the chest wall invasion.
but
بس.
with internal mammary chain, with a superior in MRI in this case, because this case it says T4A disease. You know the inner quadrant lesions, T4 disease. Yes.
Yeah, that's it. Dr. Sabri, thank you very much for your comment. And let's guys move to the next. Shabab, let's move on to next case, please.
Case scenario, breast cancer study was already.
استنى لسه ما it is not shared. يا شباب دكتور باشمهندس محمد it's not shared.
Case scenario, breast cancer study was already. I am Dr. Muhammad Mosselid, a surgeon, with my colleagues, Dr. Salwa Yahya, biologist, Dr. Ali Kamal, medical oncologist, and Dr. Samna Ahmad Amsal. The patient with skin, old, married, old, young, 6 years, on oral cyclical for 3 years, old, medical history relevant, surgical history relevant, no family history of breast cancer. Complete left breast mass, 4 months duration, April 2015, clinical examination, left breast cancer, advanced meter, left clinical examination, large size breast, no skin infection, PCP, and 2.
Biopsy from the left breast mass revealed the basis of carcinoma grade 2 with a minor globular component, no identified PCIS component, no lymphocytic combination. Immunohistochemistry revealed strong possible reaction of ER and PR, while HER2 new is negative for 0. The NPT decision was for neoadjuvant chemotherapy followed by lymphocyte radical mistake. Patients started the neoadjuvant chemotherapy and received effective care, then arranged for lymphocyte radical mastectomy on October 2018. Cross-examination of the right radical mastectomy specimen revealed free skin, free network area, only excluding defined area of measured 2.5 by 2.5 centimeter were identified, and microscopic examination of this area revealed marked tumor hyperhyalinization by marked necrosis, and the small focus viable invasive carcinoma grade 2 measuring 1 centimeter in the maximum dimension with a foci perimetral invasion, minor important DCIS and calcification. The mass is located 1.5 centimeter from the deep resection margin, which was microscopically removed. The dissected axillary lymph node were positive 7 over 17 dissected lymph nodes, some of which showing focal therapy response, the other showed viable foci with capsular invasion and very noted soft tissue extension. The case was finally diagnosed as invasive duct carcinoma grade 2 post-neoadjuvant therapy, YPT1 and 2, viability 30% and residual cancer burden class 3, resection margin to 3 and axillary lymph node positive 7 by 17 centimeter. By 17 lymph nodes, capsular invasion, very noted soft tissue extension, and focal therapy impact. Patient then received post-operative radiotherapy and will kept on adjuvant hormonal treatment start Nolvadex since December 2018 till October 2021. Then shifted to anastrozole and kept on clinical examination every 3 months and sonomammography every 1 year. The patient during follow-up complaining from bony aches in 2021 and bone scan done and was free. DEXA scan also done and show osteopenia in distal forearm and spine. Then patient in May 2022 complaining from vaginal bleeding. Transvaginal ultrasound ordered.
Transvaginal ultrasound in May 2022 showed endometrial hyperplasia reaching 16 millimeter with left ovarian functional cyst. She continued hormonal treatment and follow-up transvaginal ultrasound every 3 months was done. Follow-up transvaginal ultrasound in October 2022 showed mild decrease of endometrial thickness reaching 10 millimeter with bulky both ovaries with close follow-up. After that, follow-up transvaginal ultrasound in May 2023 revealed increased endometrial thickness reaching 19 millimeter right adnexal complex solid mass lesion with bulky left ovary and mild pelvic ascites for further pelvic MR study and tumor marker assessment. The patient was sent for MR pelvis, which revealed bilateral adnexal solid mass lesion with mild to pelvic ascites, no sizable lymphadenopathy. The masses showed low heterogeneous state of signal intensity with intense heterogeneous post-contrast enhancement. This raised the possibility of metastatic cancer breast to the ovaries.
So it is either urinary versus metastatic disease from the breast to the ovary.
Biopsy from the left adnexal mass was submitted and revealed metastatic carcinoma formed of a disease site with secondary forms, upon which we did get a 3 and we diffuse positive reaction confirming the primary breast origin with ER and PR of the strong diffuse positive, while the HER2 is negative or 0.
Tumor markers is CA 125 was 15, CA 1.47, CA 124 ratio, CA ratio was 34. Image guided biopsy done and from the adnexal mass and Dr. Hassan described the pathology. CT staging done and show only the bilateral adnexal solid masses and mild ascites, no other mets. MTT decision was the patient is metastatic for medical oncology referral. The decision was to start palliative chemotherapy, Gemzar carboplatin AUC5 for 4 cycles, then reassessment. Patient receives the 4 cycles and CT chest abdomen pelvis after the 4th cycle show.
Mild size regression convert bilateral adnexal solid mass lesions with the complete resolution of the pelvic ascites.
So you can start the discussion in this case.
شكرا. Thank you for the presenters. Dr. Ashraf.
It's a really difficult case. I think it's not Dr. Ashraf, it's Dr. Amani.
Yes.
Yes. Okay.
We have a rule.
Okay.
Well, invasive lobular carcinoma, just a little comment to our younger colleague, not the seniors. Invasive lobular carcinoma had a affinity to go transdiaphragmatic to the pelvis and also likes bone. So that's one of the characteristics of invasive lobular carcinoma. Just for the young guy, it tends to be ER positive, PR positive, HER2 negative, and it likes to go to the pelvis and bone. It's just a little side comment here. How to manage a pelvic recurrence here is really difficult cases in lobular carcinoma because they are not very good responders to chemotherapy, to our knowledge as surgeons. So I will pass it on to Dr. Amani.
Okay, the patient started the Gemzar carboplatin and she showed mild size regression. What would we go for?
Dr. Amani, thank you for this case. This is a typical character of lobular carcinoma to have a serosal infiltration. It starts usually with malignant ascites and was trans-stromic spread. It will cause Krukenberg. My addition for this case was N2 disease at first presentation after neoadjuvant treatment and still hormonal positive. Why we gave chemotherapy? This case allowed to go for fulvestrant plus CD46, either ribo or balbo or abemaciclib.
From the very beginning, I will come in here. From the very beginning?
No, as a recurrence.
As a recurrence.
Because she has a recurrence disease, pelvic recurrence with malignant ascites and confirmed to be a breast primary. what is the position of chemotherapy? Because in all trials, we are giving fulvestrant as a second line plus CD46 for those cases.
First of all, we don't have an access to the CDK4/6
Yes.
as a first line treatment for these patients. But after the treatment with chemotherapy, and now she is not responding, if she is progressed, we can send her for the
Yes.
CDK4/6 and the fulvestrant. But I do agree with you.
Yes.
Hormonal treatment is could be an option because the patient didn't show a good response to the chemotherapy from the start.
Thank you, Dr. Ramani. Just a comment about role of adjuvant chemotherapy in patients with luminal A who is a candidate only for MRM. We don't think is there any evidence that neoadjuvant chemotherapy in patient with luminal A who is candidate for MRM will get any benefit from neoadjuvant rather than adjuvant chemotherapy. This is comment number one. Comment number two, this is a very difficult case because if this case is an ovarian tumor, it's contraindicated to have a true cut biopsy from the ovary. So this is very tricky to diagnose this case because if this turned out to be a primary ovarian tumor, I know this is rare because it's multiple and this patient has breast cancer. So myself, is this if there's no any accessible lesion to be biopsied, I will go for surgery, total abdominal hysterectomy and bilateral salvage ovarectomy. Because if it's turned out to be ovarian, she will be treated as ovarian. If it's metastatic, I will not lose anything because it's not a major surgery. And if this is a primary ovarian, it's contraindicated to have a true cut biopsy from a localized ovarian tumor.
So it is very important point, and I will take from your words, Doctor, and will ask Dr. Ayman and Dr. Higazi.
But before Dr. Ayman, I will just come back to the last comment. It's a contraindicated to take a biopsy from ovaries. Are there any guidelines telling you that if you can biopsy, if it is accessible, but don't biopsy it because it is ovarian? We don't have guidelines to say that, to my knowledge.
Dr. Ashraf,
It was.
Excuse me, Dr. Ashraf.
Not now. It's mandatory.
Excuse me. It is not rare that we face cases that they have breast cancer, then they have another primary, another ovarian tumor. So usually that comes in our minds, this is a metastasis of Grubenberg tumor. But it's unfortunately some cases they are primary tumors. So for myself or what we are doing in our center, that this patient should first confirm the pathology of the ovary, and we go for laparoscopic oophorectomy, just laparoscopic oophorectomy. Then we manage accordingly if this is a new another primer or this is a metastasis from the breast cancer. So I think the best way that this patient can have laparoscopic oophorectomy for the first, then we go to manage after.
As a diagnostic procedure.
So we still need to tissue diagnose. That's what we mean. Yes. But either way.
What I'm saying, that's I agree with Dr. Gamal that I'm going to have laparoscopic oophorectomy, not
what we need tissue diagnosis.
وصح الروم صوتي طبعا بصوت الباقيين البايوبسي should have not be done. لو انا شاكك ونجذر things globular very common انها تعمل spillage في الانترابريتونال كافيتي صح هشك انها كده total abdominal hysterectomy plus bilateral salvage oophorectomy is a treatment of choice in Grubenberg. 4. Number 1, exclude the primary ovarian without biopsy. Number 2, to remove the disease without pathology. The standard is either laparoscopic bilateral oophorectomy or total abdominal hysterectomy and salvage oophorectomy.
I think we can go for retroperitoneal biopsy of the ovarian mass. Then you can avoid the peritoneal salvage. Yes.
There is no way for it.
So the comment about cystic lesion, the true cut biopsy, the cystic lesions that may cause spillage and they may cause rupture, and we are not sure that it is a metastatic disease. So we may go for rupture of double primary for new ovarian cancer. Yes. So your first choice is not that true cut biopsy from the cystic lesion in the ovary. No, they will have to go to laparoscopic assessment and laparoscopic oophorectomy for as a diagnostic and maybe therapeutic purpose. Dr. Walid, you have a comment.
هو طبعا we are lucky ان هي طلعت ميتاستاتيك، لان لو هي برايمري اوفيريان طبعا لو جينا نشوف هنقول ان هي even with the ascites هنقول it is stage 1C. لو احنا خدنا ترو كات احنا قلبناها لستيج اخرى، فعلشان كده I'm not with the احنا لاقي ان هي طلعت ميتاستاتيك، انما لو مش لاقي يبقى احنا عملنا maneuver changes the stage of the patient from early to another stage.
Even if it is a solid ovarian lesion.
Even it is even with the if there is momentum of take the biopsy from the momentum, not from the ovary. If it will not differ in metastatic cases, so we can take from the ovary because it is metastatic from the start. But in this early, if it's ovarian, it's early. It's not advanced, so try to avoid.
Okay, this situation, would you anyone would recommend for surgery at this point?
Dr. Nadia Mukhtar, I have direct question from all the panel. Can we differentiate whether it is metastatic disease or a primary ovarian cancer from true cut biopsy?
Yes, by immunohistochemistry, there are markers for the ovarian, primary ovarian, that's PAX8, and that's for sure ovarian. But if it is breast, it will not be PAX8, and it will be GATA3 positive, and GATA3 positive was done, and it proved positive, so there's no any fallacy about it being metastatic in this particular case, and in any case. From the omentum, from the ovary, even cytology can do it. And we can also apply immunohistochemistry on cytological material as well, and it's quite confident. We can also use mammoglobin. Again, it will be positive. It was not done in this case, but if you do mammoglobin and GATA3, that's sure evidence of breast versus PAX8 for ovarian.
So the true cut was enough for the diagnosis, but the concept of true cut biopsy from cystic or solid ovarian lesion that may be a double primary or a new ovarian tumor that may spillage and upgrade the stage.
Yeah, just so a clean answer, yes. True cut biopsy can differentiate between primary ovarian, except in ovarian and early ovarian tumor.
So, Dr. Yazan can go for another options for the surgical management. Do you have a surgical option or surgical rule for this case for radical intent, or it is just metastatic case to continue hair chemotherapy?
In those cases, we send them for CDK4. So this is confirmed metastatic disease. They all go for our oncologists. They'll give them CDK4 and see what's happening with the breast. So if there's the breast is mastectomy, there's no local recurrence, there's no issues, they stay on the CDK4. And what are we going to do for the surgery? There's ascites. So
we have now some very aggressive surgeons.
So even if you want to go for surgery, for aggressive surgery, you will need to give them systemic treatment for at least 6 months and repeat things and see if there is progression. We will not operate on it. And our systemic treatment will be CDK4.
Yes. It is a metastatic disease, and that's what I'm asking. What is the value of doing surgery? And she had a bilateral ovarian bulky mass with pelvic ascites, and she's not responding well to the systemic treatment, even with the chemotherapy. We didn't start hormonal treatment yet, but at this point, what is the value of going to an aggressive surgery like that? That was.
It is diagnosed.
Is there any, on the last, would there be any role for HIPIC in these cases? Has anyone had experience with HIPIC in these cases?
I think there is a bit of mix-up between surgery to treat or surgery to diagnose. So if you have an ovarian mass and you're not sure what it is, you send to the gynae, they put a laparoscope, and they might just take the ovary to confirm diagnosis. But treatment, to begin with surgery with somebody with metastatic disease, I don't think it's the correct strategy. I think it's systemic treatment. If they're responding well to systemic treatment and they're stable for months, then you can revisit that after restaging.
And we'll close here, but I would just say, no matter what you do, whether you're going to do a surgery or you're going to go for systemic therapy, I think the life expectancy here is fairly limited.
Dr.
And
Ashraf,
whether you go for surgery or go for
last
systemic
comment, Dr.
therapy, so you're going to go for the least violent way to treat such a patient, the least one with the least side effects possible.
Dr. Ashraf, if you revise this case.
The only no. So
no. دكتور حجازي قال no.
Yes.
أنا مش فاكر السؤال اللي أنا قلته بس هو قال no خلاص.
No. We'll go for surgery. So I think we have the last case and we are running out of time.
For closing,
all of us are.
I will just remind everybody.
So we can go for the last case.
The purpose of this session is not right or wrong. The purpose of this session is to incite everybody to comment for the purpose of teaching our younger colleagues.
Dr. Ashraf, if you are modifying our decision for this case to the updated data from Monarchy trial, this case should received at time of operation adjuvant abemaciclib plus AI, keeping with Monarchy trial as an adjuvant trial.
Just for you, I'm going to take off my coat because it's getting hot, these discussions now. So we go on for the next case.
Okay, last case, Dr.
Presented by Dr. Evaluated surgery, but unfortunately she's not present and needs a clinical knowledge. A 28-year-old newly married female patient presented to our center on 21 of July 2022 with large academic tail mass, biopsy outside showing invasive carcinoma grade 3. Patient discovered to be 5 weeks pregnant on presentation. On examination, right axillary tail mass about 4 centimeters in diameter with global axillary report, pathological report to be triple negative. Her ultrasound showed in largely the hypophobic lesion, in fine margin. There was also a thinner, yet smaller lesion. Appears adjacent to such a large lesion, and as really includes appear pathological. Secondary blunt biopsies from the right snap and the right axillary lymph node will take inside the leg and the the biopsy from the breast mass revealed a high level of carcinoma. The other biopsy, the right axillary lymph node was negative to lymphocyte. Chemically, this is a negative residue. MDT discussion for July 2022, surgical MDT decision and surgical review regarding age of the pregnancy and discussion of the patient pool. Either upfront radical versus termination of pregnancy to start the adjuvant. This is the NCCN guidelines about patient pregnancy in the first trimester. After prolonged discussion with the patient, she approved for going for abortion on 10th of August 22, and 1 week after termination of pregnancy, the patient had been sent for CT staging and after consultation for mammogram. The contrast enhanced mammogram showed an area of heterogeneous non-mass and mass and non-mass enhancement extending in the upper outer quadrant, which is considered multicellular necrosis.
and on CT staging confirm the presence of the mass and the lung and liver were free of dust. After the results of the staging, the patient was fed back again for the ABT on 2022. The decision was for starting neoadjuvant treatment followed by surgical review regarding skin sparing mastectomy, sentinel leg wounds and reconstruction. While the patient is ongoing on the CT staging and the MDT, she was fed for MD preservation. On 23 August, she started neoadjuvant chemotherapy. She received 4 cycles of ASD, followed by taxol carboplatin with monthly Zoladex for ovarian preservation. She ended the treatment at 5th of June of January with very good response and toxicity reported to the patient and referred back for the MDT surgery. Patient underwent rice sparing mastectomy with axillary clearance and VTR, and that is like that. Sorry. Then the patient went for reconstruction.
Specimen, the skin is very biopsy. The skin is very Syria and shows the identified area, 2.6 meters, located 0.5 centimeters from the superficial mark, and 3 centimeters from the deep margin. The left mount, and the left standard the microscopic examination of this area will be a marked surface response. With a marked tumor fibroorganization, mild inflammation with the stomach reaction, with no residual viable tumor cells, the resection mark were also free, and the cells of the left lung were negative, few of the third level tumors.
Patient ended the full course of post-operative therapy, and now she's on the follow-up, and she's wishing to start for the wish. Thank you.
How big was the largest tumor? How big was the largest tumor at presentation? 4 centimeters. We'll just start with a simple question to the radiation oncologist. I don't know whether Dr. Ahmed Amin is here or not. Ahmed, in a node-negative disease with multifocal disease, the largest focus is 4 centimeters. Post-surgery and still node-negative, preoperatively or pre-chemotherapy, node-negative. The largest focus is 4 centimeters, although it was mentioned might be a multifocal. Is radiotherapy indicated after mastectomy?
In general, after mastectomy, radiotherapy is only indicated if we're having a larger T3 tumor or positive lymph nodes. But with T2 and zeros, there is no benefit from radiotherapy.
But she did receive radiotherapy. That's why I wanted to comment about it. The largest focus was 4 centimeters. From the very beginning, she was not negative. Okay. Was there an indication for radiotherapy in this case?
If the scenario is like this, I don't think there's indication.
It's just a side issue. Again, for our younger colleagues to learn about it, is that there is not really an indication here. Although we surgeons sometimes, when we do nipple sparing mastectomy, skin sparing mastectomy, and we feel intraoperatively that we left a bit of breast tissue, might be a reason, but the standard is
still mastectomy. Even nipple sparing, it's mastectomy. Yeah.
Do we have any comment?
Good evening, everybody. I just have a question. It's kind of radiology and surgery. It's actually for the surgeons. For such a case, when we have non-mass enhancement, what are the data that you wait to have from us to decide whether you can do a skin sparing mastectomy? I'm not talking about the primary that is 4 centimeters. I'm talking if we have a non-mass enhancement per se. what are the data you're waiting for to do a skin sparing mastectomy?
Dr. Husseini, what would you expect from the radiologist to mention the details for you about the non-mass enhancement, the extension of the non-mass enhancement, and what's your decision? How did the non-mass enhancement will change your decision?
For sure, non-mass enhancement is one of the gray zones in the MRI, and we always fight with our radiologists about this added value of the non-mass enhancement. But the question is this non-mass enhancement related to the primary region or not? Extension to what area of extension? And what is the response of this non-mass enhancement to the neoadjuvant setting? Because sometimes we found that this non-mass enhancement is present in the other breast. Okay, so it is not always non-mass enhancement does not mean all the time that there is malignancy there. This should be put into consideration, and we should receive enough data about how much you are serious about this non-mass enhancement. This is
no, if it's pathologically proven. I mean, now in Baheya you have contrast enhanced mammography biopsy.
Okay.
So you can take a vacuum biopsy from the non-mass enhancement.
Okay.
It's pathologically proven to be malignant, and you're deciding now what to do for the patient.
So it is related to the breast cup side and the area, the size of the area involved, just like this.
Okay.
I think
the relation, the distance from the skin and the distance from the nipple is mandatory to decide whether to do a skin sparing or nipple sparing operation.
No, but
Mm.
for non-mass enhancement, sometimes it will help us in the gray zone. Like if we have tumor like that, 4 centimeters, and we have cup B, and then it will act like 40% of the tumor size, and then you say there is non-mass enhancement, so you will think about it will act like 70% of the tumor size, even if I'm not sure that it's positive for malignancy and I'm not proved. So sometimes it helps you to make a decision for you. Okay, it will be easy for me, or maybe in my point of view, more safe to do nipple sparing or skin sparing mastectomy rather than conservative breast surgery. So sometimes it helped me in make a decision, not as Mahmoud says, sometimes in the gray zone, it will push you in one decision against the other.
Till you're waiting for me to tell you the distance from the nipple and the distance from the skin.
Okay, so this is the importance of the MRI report for myself, that when I'm going to have the patient going to have a nipple sparing mastectomy, not skin sparing mastectomy. So the decision for pre-operative, the extent of the tumor, how far from the nipple, or maybe this can differentiate. So if the decision skin sparing from the start, it will, the decision will not affected by the radiology. But when it's talking about nipple sparing mastectomy, I'm going to wait for your.
Just a question to most surgeons here. Okay. Do you rely on radiology to tell you the distance, or you rely on your clinical
question? I think to the radiologist as well as a surgeon. If you have a non-mass enhancement is not accessible for biopsy, whether by contrast mammography or ultrasound, we don't have him get biopsy, I know. So if this is only non-mass enhancement, not seen by ultrasound, not confirmed by contrast mammography, what you are going to do with these patients? You do a mastectomy or skin sparing mastectomy, or you just ignore it? I'll give you the question to the surgeon first, please, followed by the radiologist.
Just to comment about the nipple. If the non-mass enhancement is reaching the nipple, then you might make the decision to remove it. If it's close, it will not change my decision. I will do a nipple sparing, we'll do a retroauricular biopsy on table. If it's positive, we take it off. If it's negative, we'll keep it. If the final pathology comes back still that is positive, even with a negative possible frozen section, you know where the nipple is. It's very easy to take it off. So you know that you get a clear margin. So if it's not directly involving, it will not change my decision. For the skin, if it's not directly involving, it's also the same. If I feel that there's a good distance, I will look always at the scans. Then I will do a skin sparing. If I feel it's close, we can do a skin reducing. So you can take a bit of that skin and do a skin reducing with a different patterns. I think you can do a vertical scar, You can do a lateral. So there's different patterns. So I always look at my scans. Yes, it will help, but it will not change my decision without looking at the scan.
It's a pure clinical decision after studying everything. It's the surgeon's decision what to go for. Is that correct?
Okay, so here, if you're talking about a non-mass enhancement, this means that this is not a mass. This could be only DCIS or some kind of a very, very early disease. So it couldn't breach the fat tissue subcutaneously. So if you're a good surgeon, if you're trusting your surgeon, the surgeon will keep the plane just under the skin in the subcutaneous fat tissue. So there wouldn't be any problem, but this is only for the skin. But it's totally different for the nipple, because there you have the tissue going up to the nipple. So there we should depend on your report. But for the skin, if you, for example, I always read the MRI by myself. I'm the surgeon. I am the driver. So that's why if I don't read the MRI before surgery, I wouldn't feel myself safe on the name of my patient as well. So not depending only what you're writing on your report, I have to see it by my eyes. And just to calculate how I can go under the skin in the plane of the subcutaneous tissue. With this, up to now, very few patients had a very close margin. And also during the surgery, if you have a good pathologic backup, and then you can ask your pathologist when you just market it, and they can make a touch print and they can tell you whether this is that there's any positivity or not. So with that in mind, then we can make a skin reducing, skin sparing mastectomy as well.
So it's a little message to our younger colleagues here is that, yes, the report is fantastic, but you have to see the images yourself as a technician in the operating room, because it will help you a lot. But just another note, and then Dr. Amani will have a question. If this patient refused abortion and she's in the first trimester and you decided to go for surgery, clinically not negative, would you go for sentinel node or clearance? Why? Is sentinel node a contraindication in pregnancy?
I stop only.
That's it. No, I stop only. So if you have that, I don't. No, I'm not talking in Egypt. I have got our guys from our sister country, Turkey, and I'm sure they are fantastic. And it's my second favorite country. And if they have the radioactive isotope, yes, it is proven that you can use it in pregnancy, but not the patent blue because of the risk of anaphylaxis, but not contraindication.
Dr. Ashraf, I just want to comment on surgeons reading MRI. Surgeons reading contrast mammography, I accept, but reading MRI, no. If it is with you, it's not with 90% of the surgeons.
Look, can I make a comment? Can I make a comment? Look, the only thing that I can tell you that if you're a human being and who can read an MRI, though anybody who is a human being can read it after.
I say I'm a human being, I can go and operate in fibroadenoma.
Yeah, but
that's not acceptable.
That's okay.
It's not acceptable. It happens, maybe you are experienced in MRI, but if I ask 90% of the surgeons in this room, if I give you an MRI examination without the report, 90% of them would say, no, I need the report. And that's what happens actually in the MDT. We have excellent surgeons working every day with breast in breast cases. Meher, when we are sitting in the MDT, do you accept it? Do you tell me I don't need your report, and I don't need your comment?
Only on contrast mammogram. Contrast mammogram for me it is a very good tool, better than MRI because the dynamic curves of the MRI.
Only one word. I'm not saying that every surgeon should read it. This is my philosophy, and so this is my way, because I need to care my patient, and I have many radiologists from there to up there. So I need to trust myself. That is why. So there are lots of radiologists who are reporting. Can you tell me that every radiologist has a good reading on MRI? No.
Can I ask you one question?
Yes,
do you agree that multidisciplinary management of breast cancer is much better than individual management? If we're going to say that we're going back to individual management, we're going back.
Okay, let me rephrase. I never read the MRI by myself, always the radiologists here together.
Yes,
this is a multidisciplinary team. But again, only depending on the report is not my way. Always, I have to keep and my radiologist beside me and read it on the screen together.
But what I believe in is if the radiologist is working close with the surgeon, he will give him exactly the report that he needs. He will give him the information that he needs without getting the effort to look at the.
Believe me,
Yes.
this is not correct.
No.
Okay, let me cut this.
Let's go back. Let's go back to the
Just
original
another
question.
comment, because it's as if we accepted that every non-mass enhancement is a DCIS, so it won't invade the subcutaneous tissue. This is not true, because most lobular carcinomas present as non-mass enhancement. A large percentage of lobular carcinoma present as non-mass enhancement, and non-mass enhancement doesn't mean that it is not a malignant tumor. No, we have a lot of lobular carcinomas, tubular carcinomas presenting as non-mass.
Before we close this session, I will just have one comment. When we say as surgeons that we look at the X-ray, we are not looking at the X-ray to make a diagnosis. We are looking at the X-ray to help our incision. And now we have a final. You've been warned when I took off my coat. You know that I'm going to incite a fire.
It is not a surgical MDT. Okay, I want to ask the question. Do you think, for the medical oncologist, do you think the Zoladex is enough for fertility preservation for these young patients, or should we go for embryo preservation? I want to comment, Doctor.
A very good question for this young lady, because she discovered breast cancer during pregnancy, and she did an upfront surgery followed by a chemotherapy, as I know. I think that ovarian preservation have a lot of maneuvers. One of the maneuvers is with letrozole, biletrozole, to have more oocytes. We have a cryopreservation or oocyte preservation. My big question here in this case is a triple negative disease, and discovered her breast cancer during pregnancy. I think he should wait for 2 years for to stability after finishing of radiotherapy and chemotherapy to have a chance for pregnancy, because challenging with pregnancy in the adjuvant setting, especially in the first 2 years, is a risk for her.
Oh, thank you very much. And with that question and that answer, if you have a comment.
Zoladex alone is not that effective. It's effective, maybe it preserves the menstruation, but it not preserves the fertility itself. So Zoladex alone will help, but not as effective as oocyte preservation or embryo preservation. So embryo preservation or oocyte preservation is the standard plus Zoladex.
In this case, I'm sorry, I should have closed, but I'm going back to this. If you have a patient who's had surgery, she needs chemotherapy, and then you decide to do some preservation of her fertility, isn't it going to delay the start of chemotherapy?
The standard of care, you should start chemotherapy within 3 months. We used to use chemotherapy within 4 weeks, but now they allow up to 3 months, and because of that, patient can go for oocyte preservation. It takes maximum 1 month, because usually they start after the menstruation, and it will take about 2 weeks. So ovarian preservation will not delay much the start of chemotherapy.
Thank you very much for this.
Thank you very much. استاذن حضراتكم، احنا هناخد الصوره الجماعيه وبعد كده ان شاء الله هنتوجه على الجاردن جنب اللوبي، جنب الريسبشن على اليمين. بس انا استاذنكم نطلع على الستيج عشان ناخد الصوره الجماعيه الاول يوم.
فاضل اليوم ده شغال
كده باقي
ماشي معاك دكتور مين؟
لا استنى، في واحد